ગુડ મોર્નિંગ ઓલ. આપણે સીએમઈ ચાલુ કરીએ, બહારથી બધાને બોલાવી લેજો જેટલા હોય. Good morning all, welcome all the attendant on behalf of Rajkot IMA. I welcome you all. After a small pause from the corona third wave, we are again starting our activities, and we are starting with the academic activity which is CME today, and this would be our last CME for our IMA committee of 21-22. This is our own family function like event, because Prime Hospital is our own hospital and all the doctors are our like family members. So on a daily basis or whatever the CME we are conducting on all of the year, most CMEs are from outside the Rajkot hospitals. They are marketing here, but this is our Rajkot own hospital, and this CME is like our family function. So I would like to call Dr. Praful Kamani sir for inauguration speech, and then we will have a small inauguration Deep Pragatya function, and then we will start our CME.
Good morning all. Behalf of Indian Medical Association Rajkot, I welcome you all delegates, and thanks to Prime Hospital for arranging such a nice CME which is very useful in day-to-day practice. જે રીતના દુષ્યંતે વાત કરી કે સિમ્સની CME હોય, અપોલોની CME હોય, કોઈ રિલાયન્સની CME હોય, પણ આપણા જ ઘણી બધી પાસ્ટમાં CME થઈ ગઈ. હાર્મોનીએ કરેલી હતી, ગોકુલ હોસ્પિટલે કરેલી હતી. પ્રાઇમ પણ એવું કીધું કે અમે દર વર્ષે CME કરશું. એટલે બિગ થેન્ક્સ ટુ પ્રાઇમ હોસ્પિટલ. એવરી યર હી વિલ ડુ CME એટ IMA રાજકોટ. ડૉક્ટર કે રાવલ એ અમારા ગેસ્ટ્રોના ભીષ્મ પિતા છે. જેમ હેમાની સાહેબ આપણા IMAના ભીષ્મ પિતા છે. અમે જ્યારે કોઈ પણ પ્રોસેસમાં ફસાઈએ ત્યારે સાહેબ રાઉન્ડ ધી ક્લોક અવેલેબલ હોય છે, વિધાઉટ ચાર્જ. ERCPમાં અમે ફસાઈએ, કોમન વસ્તુ છે અમારા માટે. એટલે સાહેબે અમને ગમે ત્યારે કોઈ પણ પેશન્ટનું સેકન્ડ ઓપિનિયન હોય, ક્યારેય પેશન્ટ સાહેબ પાસે જાય તો ઓલવેઝ પોઝિટિવ અને ઓલવેઝ હેલ્પફુલ નેચર. IMAની વાત કરીએ તો અમને પણ ખબર નથી પડી કે કેમ 10 યર અમારું પૂરું થઈ ગયું. હવે થોડી જ ઇવેન્ટો બાકી છે, લાઈક નેક્સ્ટ વીકમાં આપણે ઓલિમ્પિક કરવાના છીએ શનિ રવિ, તો એમાં પણ બધા મેક્સિમમ ભાગ લઈએ. આ ઓલિમ્પિક ઘણા ટાઈમ પછી થાય છે. એમના પછીના વીકમાં ધૂળેટી આપણે આંગણ રેસ્ટોરન્ટમાં આપણે ઉજવીએ છીએ, જે ગિરાજ હોસ્પિટલ સ્પોન્સર કરે છે. ત્યારે મોર્નિંગમાં બ્રેકફાસ્ટ અને થોડું ધૂળેટીનો એ આપણે ઉજવશું, સેલિબ્રેટ કરશું. એ તારીખ 18 છે, રવિવારે, ફ્રાઈડે છે 18 તારીખે. ત્યાર પછી 3 એપ્રિલ સન્ડે ઇવનિંગ હેમુગરી વોલમાં ઇન્સ્ટોલેશન સેરેમની છે. ત્યારે ડિનર પ્લસ ફંક્શન હશે, તો બધા જરૂર એટેન્ડ કરશો. આ CME માટે જે બધા સ્પીકર્સ છે એ બધા પોતાના ફિલ્ડમાં બહુ એક્સપર્ટ છે. આઈ રિક્વેસ્ટ ટુ સ્ટીક ઓન ટાઈમ. મેક્સિમમ પરમિસિબલ ટાઈમ બિયોન્ડ લિમિટ ઇઝ 5 મિનિટ્સ, કારણ કે એની વચ્ચે આપણે કંઈ પણ ઇન્ટરેક્શન કરી શકીએ, કોઈ ક્વેશ્ચન આન્સર કરી શકીએ. નાવ આઈ રિક્વેસ્ટ ઓલ પ્રાઇમ ટીમ મેમ્બર ટુ કમ front and will proceed for Deep Pragatya.
Parasbhai, Amitbhai, all senior IMA committee members, please come on the stage.
સાથે જ એક ગ્રુપ ફોટો પણ આપણે કરી લઈશું. ઠાકરજી પાછળ બેકગ્રાઉન્ડ કદાચ ગ્રુપ ફોટો માટે. So, good morning, friends. ઇન્ડિયન મેડિકલ એસોસિએશન રાજકોટની પ્રથા પ્રમાણે આપણે હવે શરૂઆત સમયસર કરવાની પૂર્ણ કોશિશ કરી છે, and we are trying to stick on time. So, introducing the first speaker for the CME from our own hospitals, and that's Dr. Amit Rathod. Is a senior oncopath. I'm sorry. I'm really sorry. So before we proceed towards the CME, I would like to welcome the senior most gastroenterologist from our own city, the most respectable Dr. K.K. Rawal sir, who has initiated a beautiful task of starting a specialty hospital in our own city. એક નવો જ concept સાથે, પણ ખૂબ જ જરૂરી, ખૂબ જ અગત્યનો concept. And where under one roof you can have all the facilities of GI, including the diagnostic and therapeutic and the intensive care also. So I request Dr. K.K. Rawal sir to please come forward and have a welcome address. A big round of applause for Dr. K.K. Rawal sir and the team Prime. Thank you.
On behalf of Prime team, I welcome you all. I thank Dr. Praful Kamani and Dr. Dusyat Gondalia and other office bearers of IMA for giving us this opportunity. એક બીજી વાત તમને કરી દઉં કે અમારી એક સોસાયટી છે, ઇન્ડોસ્કોપી એન્ડ ગેસ્ટ્રોએન્ટરોલોજી સોસાયટી ઓફ રાજકોટ, જેનો પ્રેસિડેન્ટ પ્રફુલ છે. એન્ડ આઈ એમ રિયલી પ્રાઉડ, મને બહુ ગર્વ થાય છે કે અમે અમારી સોસાયટી એટલી કોર્ડિયલ ઇન્વોલ્વમેન્ટમાં કામ કરે છે કે અમે એક પણ બીજાને રેફરન્સ કરીએ છીએ. જેમ પ્રફુલ્લે કીધું, વી આર વેરી, આઈ એમ પ્રાઉડ and I'm privileged to have such colleagues with me. Hats off to them. હું તમને પ્રાઇમનો થોડોક ઇતિહાસ બતાવી દઉં. 1996માં હું રાજકોટ આવ્યો. 20 વર્ષ મેં પ્રેક્ટિસ કરી. પછી મને લાગ્યું કે આઈ એમ નોટ હેપી. મારી ગતિ હતી પણ મારી પ્રગતિ નહોતી. એનું રીઝન હતું કે ઘણા બધા પેશન્ટ યુએસ કે ઇન્ટરોસ્કોપી, પીએચમેટ્રી, મેનોમેટ્રી, ફાઇબ્રોસ મને બારે મોકલવા પડતા હતા, કેમ કે મારી પાસે એ ફેસિલિટી નહોતી. પછી મેં વિચાર્યું કે એક ટીમ બનાવવી જોઈએ. જેમ આપણે પ્રધાનમંત્રી કહે છે ને, સબકા સાથ સબકા વિકાસ. મેં એક ટીમ બનાવી અને મારી ટીમમાં પહેલાં ડૉક્ટર અવલ સાદીકોટ સાહેબ, હુ ઇઝ વન ઓફ ધ બેસ્ટ હેપેટોલોજિસ્ટ, ડૉક્ટર ચિંતનકન સાગરા, હુ ઇઝ અ પેન્કેટોલોજિસ્ટ એન્ડ આઈબીડી સ્પેશલિસ્ટ, યુએસ સ્પેશલિસ્ટ. પછી ધીરે ધીરે ડૉક્ટર અમિત આચાર્ય, હુ ઇઝ વન ઓફ ધ રિનોન્ડ એન્ડ સિનિયર સર્જન ઓફ જીઆઈ સર્જન એક્સક્લુઝિવ ઓફ રાજકોટ. પછી ડૉક્ટર ધ્રુવ દેસાઈ, હુ ઇઝ અ પેડિયાટ્રિક ગેસ્ટ્રોએન્ટરોલોજિસ્ટ એક્સક્લુઝિવલી ફોર ધ ફર્સ્ટ ટાઈમ ઇન અવર સિટી. પછી એમ ધીરે ધીરે આઈસીયુની ટીમ, ડૉક્ટર બુધવાની, ડૉક્ટર જીગર ડોડિયાની ટીમ, એવી રીતે રેડિયોલોજી લેડ બાય ડૉક્ટર ધવલ ધીંગાની. એવી રીતે અમે મેટાબોલિક સર્જરીની અમારું જે ડિપાર્ટમેન્ટ છે, દેટ ઇઝ હેડેડ બાય ડૉક્ટર મોહિત ભંડારી, હુ ઇઝ વન ઓફ ધ લીડિંગ બેરિયાટિક સર્જન ઓફ ધ ઇન્ડિયા, રાધર ધ ફર્સ્ટ. એવી રીતે અમારી ટીમ આગળ વધતી ગઈ. બધું કોન્સેપ્ટ એક સાથે બધાને ભેગા કરવાનો. દેટ વી અમારી જૂનાગઢમાં અમારી બ્રાન્ચ છે, વિચ ઇઝ હેડેડ બાય ડૉક્ટર ચિંતન મોરી. ડૉક્ટર વરુણ શુક્લા ઇઝ અવર સ્કિલ્ડ ઇન્ડોસ્કોપિસ્ટ. ડૉક્ટર લાડુ મોર સાહેબ ઇઝ અવર ફૂલ ટાઈમ એનેસ્થેટિસ્ટ. આવી રીતે અમારી ટીમ બની. અવર પર્પસ વોઝ ટુ ગીવ સ્કિલ્ડ, highly advanced, technologically advanced care under one roof. Everything in gastroenterology we are catering. And this is not possible without your support. સાહેબ, પ્રાઇમ એક નાનું 5 વર્ષનું બાળક છે. એને તમારા સપોર્ટની, તમારા આશીર્વાદની, તમારી અપેક્ષા છે ઘણી બધી. પ્લીઝ એનું ધ્યાન રાખજો. ઇટ ઇઝ નોટ પોસિબલ વિધાઉટ યોર સપોર્ટ. થેન્ક યુ. આભાર.
સર તમારો વિડીયો પ્લે કરો પ્રાઇમનો. CME સ્ટાર્ટ કરીએ.
So, first speaker is Dr. Amit Rathod, a close friend of mine, a colleague, a senior oncopathologist, and he has been trained extensively in the field of oncopathology. And today is going to give us some insights about GI gimmicks and its diagnostic approach. So, Dr. Amit Rathod, the opening batsman for today's CME, I request Dr. Amit Rathod to give the deliberation for today.
Thank you, Dr. Paras, and very good morning, all of you. I hope you all had a wonderful breakfast and still will have a long academic feast. So, without wasting much of time, let me come to my point. So, today's point is a diagnostic approach of gastrointestinal disease. These are the routine gastrointestinal disease that we come across in our day-to-day practice, and we are using so much of diagnostic tool to reach at the exact diagnosis of all this disease. Apart from routine investigations, we are widely dependent on the histology and cytological diagnosis that we are using widely for the exact diagnosis of all this disease. And today I will focus more on this histo and cytological investigations rather than the routine investigations. So coming towards first, I'm starting with the cytology. So cytology, basically it's just an examination of cells, right? And we are using three methods of cytology: FNAC, brush cytology, and fluid cytology. FNAC, you all must be knowing, it's nothing but it's a fine needle aspiration cytology, right? In FNAC, what we are doing, we take out the material from the lesional area and spread it onto the glass slides and examine it under the light microscopy, right? The FNAC, it's actually very easy and OPD procedure whenever we are dealing with patients having the tumor on the body surface area. But we have to use some specialized techniques whenever we are dealing with the patients with any visceral tumorous pathology. So if I talk about the GI tumorous pathology, we are widely using the EUS guided FNAC and brush cytology in our setup. So what is EUS guided FNAC? See, EUS guided means endoscopic ultrasonography guided FNAC, right? And we are using widely for the pancreatic, perigastric, mediastinal lesions, as well as perigastric, retroperitoneal, and mediastinal lymphadenopathies. Let me share you one short video how we are taking the EUS guided FNAC. See, our ultimate aim of EUS guided FNAC to take out the material from the lesional area, right? So this is the scope that we are using, and we are trying to take out the material from the lesional area and with the help of the ultrasonography, right? Here you can see, the to and fro, yes, this is the to and fro movement of the needle that we are trying to take out the material from the lesional area, right? Yes, and after taking out the material, we put it onto the glass slides and we prepare the smear. Here you can see some mucinous kind of material that has been taken out. So after preparing the cytology smear, we'll have to fix it with the proper cytofix material, and then after proper HN stain, we'll have to examine it under the light microscopy. Yeah. See, this entire procedure is done within the OT complex area. So it takes the advantage of early diagnosis, and then we can guide our consultant accordingly. Yeah, so this is a short video of US guided FNAC. Let me share you one interesting case that we had came across before a couple of days ago. See, this was a male 40 years presented with the mediastinal lymphadenopathy. And overall, on a clinical grounds and on the imaging finding, we were suspecting it to be a malignant etiology. So we did the US guided FNAC of the patient. And the picture was like this. See, it shows a large area of caseation necrosis, right? And at places we are able to find the nice epithelioid granuloma. So ultimately, we have to label this patient as a caseating granulomatous lymphadenitis. This is another case. Female, 45 years. This lady presented with pancreatic lesion, and we did the US guided FNA. This section is from the cytoblock, the cytoblock study, and on the left side, this whole thing is normal fatty tissue and pancreatic tissue, and on this right side, this entire thing is the tumor. And on the routine histology as well as on immunohistochemistry, it was labeled it as a pancreatic neuroendocrine carcinoma. We had been seen many perigastric patients, and we did the US guided FNAC on all these patients, and we came across with the different diagnoses. It could be a GIST, it could be a lymphoma, it could be a neuroendocrine tumor, or it could be adenocarcinoma as well. So this is all about the US guided FNAC. Now coming next towards the brush cytology that we are also using routinely in our day-to-day practice. So brush cytology that can be useful in whenever we are dealing with the pyriform fossa or cricoid tumor or any other gastrointestinal tumor. And the main advantage of this brush cytology is the turnaround time. So we can able to give the report within 2 to 3 hours, and most of the times we may able to give the exact diagnosis as well. So these are the colonoscopic and gastroscopic and CBD brushes that we are using in our setup to take the brush cytology. So this is again this interesting case, male 65 years old presented with circumferential mass in the rectum, and we received the unstained slides from the rectal mass, and here you can see the malignant epithelial cells that are arranged in the glandular form in the necrotic background. So it was called it as a adenocarcinoma of rectum. This is again 62 years old lady presented with CBD strictures, and we received the cytology smears that shows some malignant epithelial cells arranged in the glandular form, and so it was also called it as a adenocarcinoma. See, as far as cytology is concerned, there are some limitations of cytology you must be knowing, and there are few tumors that mimic each other on cytomorphology. If I talk about the poorly differentiated carcinoma, If I talk about the poorly differentiated carcinoma versus lymphoma, if I talk about the adenocarcinoma versus neuroendocrine carcinoma, in all these tumors, the cytomorphology is almost similar. So we have to take the, the help of the biopsy diagnosis, that is histopathological. And obviously, some low-grade epithelial malignancies and benign GI pathology, we have to take the help of the histopathology. So now coming towards the histopathology, histopathology is nothing but it's just the tissue diagnosis. So we are using the 3 techniques of histopathology: routine histology, spatial stain examinations, and immunohistochemistry. Routine, it's just H&E stain sections, and it is useful for the many benign as well as malignant pathology. Spatial stains we are widely using for some fungal infections, and also we can use it to differentiate the type of malignancy whenever we have doubt, whether it is adenocarcinoma or squamous carcinoma. We can always use the spatial stain. And immunohistochemistry, you must be knowing that that is useful in some of the diagnostic dilemma to differentiate the exact categorization of tumor, whether we have a doubt, whether we are dealing with carcinoma or lymphoma, whether we have a confusion with subtyping of the round cell tumor and subclassifications of the lymphoma. So now let me share you some benign cases of GI pathology. This is a colonic biopsy from the young male patients, and the biopsy shows the colonic gland, that is the architecture of the glands is effaced, and the lamina propria shows intense inflammations, and there is a cryptitis, and here you can see the crypt abscess formation as well. So we called it as a ulcerative colitis. Yeah, this is again biopsy taken from the gastric region, stomach, and you can see the benign gastric glands, and the lamina propria is infiltrated by the intense acute and chronic inflammations. It shows so much of activity, and if you find the lumen of the glands, you can find the pink bacilli. That is nothing but it's a H. pylori bacilli, so it was labeled it as a H. pylori induced chronic active gastritis. Yeah, see, this is again interesting case. Male 70 years old presented with mass in the mid esophagus, right? We have taken the brush cytology as well as biopsy in this patient. Unfortunately, breast cytology was showing nothing. It was benign, because you can see the normal squamous epithelium overlying the tumor, and the tumor is lying entirely just beneath the squamous epithelium. So we didn't get anything from the brush cytology, but in histology you can see this whole thing, that is a malignant squamous proliferations, and so it was labeled it as a squamous cell carcinoma. Yeah, that's another case of squamous cell carcinoma of esophagus. Yeah, this is another case, 67 years old lady with lower end of esophageal ulcer. The biopsy shows the mildly hyperplastic squamous epithelium, and the tumor is this. This is the malignant glandular proliferations just beneath the epithelium. So it was labeled it as a adenocarcinoma of esophagus, lower end of esophagus. That's the same another case of adenocarcinoma of stomach. This is the biopsy taken from the pancreatic lesions, and it shows the the malignant tumors that is arranged in the cords and trabecula. So on the basis of histology and immunohistochemistry, we labeled it as a neuroendocrine tumor. And all in all, and at the end, I should conclude my talk that see, we are taking a great help of histology and cytopathology to reach at the exact diagnosis of all GI pathologies. And we have seen so many patients presented with the same clinical pictures and complaint, but the histo and cytopathological examinations reveal so many suspects with different diagnoses. And finally, I must say that we pathologists, we are playing a very crucial and important role to reach at the exact diagnosis, and our meticulous diagnosis makes proper further management of the patients. And so we all, with all these specialized techniques by our expert team, we can show satisfactory results to our patients. Thank you.
Amit, I have two questions.
Yes, sir, please.
it gives so much relief if we diagnose tuberculosis,
Yes,
because
yes.
patient relative are so painful condition.
Right,
Just
right.
you take brush and within 10 minutes you can give diagnosis.
Right.
It's excellent.
Hmm.
Second, tell me about immunohistochemistry. Where it's required, what is the cost, and what gives much information than routine histopatho?
Yeah, yeah. Sir, as I told you, sir, actually immunohistochemistry we are using whenever we have a, we have a, some problem with our routine histology. Whenever especially we are dealing with, whether it is poorly differentiated carcinoma or whether it is lymphoma, whether it is carcinoma or whether it is neuroendocrine tumor. If I can say if it is lymphoma, but still we have to further subclassify the lymphoma. Okay, what type of lymphoma, whether it is Hodgkin's or non-Hodgkin's. If it is non-Hodgkin's, then what are the subclassification? I mean, which are the subclassification of non-Hodgkin's lymphoma, whether it is B cell or T cell or like this. So in all these cases, we have to use the the immunohistochemistry examinations in all these cases.
If you come across the patient relative, just you counsel him. Sometimes અમે એન્ડોસ્કોપી કરીએ ચાર્જ લઈએ 4000 રૂપીસ, પછી બાયોપ્સી માટે પેશન્ટ જાય એટલે બીજા 1500 લઈએ, પછી ઇમ્યુનોહિસ્ટોકેમિસ્ટ્રી કરવા આવે ત્યારે પાછો ચાર્જ લઈએ, તો પેશન્ટ રિલેટિવ આર સો ફેડ અપ. તો એટલીસ્ટ એટ ધેટ પોઈન્ટ ડ્યુરિંગ સબમિશન યુ શુડ ટેલ કે આ રિપોર્ટ્સમાં કાંઈ નહીં આવે, આગળ રિપોર્ટ કરાવવો પડશે, તો યુ હેવ ટુ સ્પેન્ડ સમ મની, સ્પેન્ડ સમ ટાઈમ, કારણ કે પેશન્ટના રિલેટિવ એટલા બધા પેનિક હોય છે
Right.
જસ્ટ ધીસ ઇઝ માય સજેશન.
Yeah, no, definitely, sir. We'll take care of it, and routinely we are doing this type of practice. If at all, if it is required for the further processings or further any, the further investigations, we'll let you know. અમે પેશન્ટને એકચ્યુઅલી કહેતા હોઈએ છીએ કે જો જરૂર પડશે તો અમે તમને આગળ એક્ઝામિનેશન માટે કહેશું એમ. Anything else?
Thank you. Thank you for the excellent session. I request Dr. Anand Poptani sir and our GSB Vice President Dr. Amit Agrawat to felicitate Dr. Amit Rathod and Dr. Praful Kamani and Dr. Dushin Bhai to do the honors. For the Thank you, Amit. It was a nice lecture, Poptani sir. Thank you. For the next lecture, I request Dr. Dhaval Dhingani, who is a senior radiologist practicing at Unity Imaging Center, is going to give deliberations of GI radiology, old versus new trends. And so happy to see that ek state level ni conference ho, e રીતનું transmission ને બધું થાય છે. So that's hats off to Dr. Praful Kamani sir and Dr. Rahul sir for such a great initiation. Thank you.
Very good morning, all respected seniors. Continuing the diagnostic part, we will go through radiological investigation in gastrointestinal tract in terms of older versus newer methods. Now, gastrointestinal system is one of the largest system of body affected by wide range of pathologies, and with modification in lifestyle and environmental changes, we are seeing newer diseases with increasing complexity. To meet these challenges, diagnostic methods are also evolving from time to time. These are the various imaging modalities in radiology, in which X-ray and contrast studies are very basic and oldest methods. Then ultrasound abdomen or sonography is most commonly prescribed method for screening. Then we have contrast enhanced CT scans and other cross-sectional imaging modalities like CT angiography, MRI, MRCP, ERCP, and nuclear scans. So starting with the older methods, in the earlier days of medical practice, there were only two methods for evaluation of GI tract. One was conventional radiography, or popularly known as plain film abdomen at that time, and another was barium study. Fluoroscopy is real-time evaluation of gastrointestinal tract after ingestion of oral barium sulfate. At that time, it was considered as hero because it is the only advanced imaging modality at that time. All radiology trainees were keen to learn this technique of fluoroscopy, and those who were able to master this technique were considered as super specialties at that time. But nowadays there is limited role of these two imaging modalities. So X-ray abdomen is indicated only for few of the conditions like diagnosis of small bowel obstruction, intestinal perforation, and suspected case of foreign body ingestion. In these cases, it will provide diagnostic findings like multiple air fluid levels in case of obstruction and free gas under the diaphragm in case of perforation. However, it will not provide idea about the main causative factor, its associated secondary changes and complications, which will eventually need to know for definitive management. Similarly, in case of foreign body, it will give rough idea about location, but other details will not be possible. Now coming to the contrast studies, they are performed with oral barium sulfate, which is water insoluble material. In the past, it was considered as a reference standard for evaluation of gastrointestinal anatomy as well as pathology, as endoscopy at that time was performed with non-flexible metal straight endoscope, limiting the use of procedure. Different barium studies which we have are barium swallow for esophagus and proximal stomach, barium mill for stomach and small bowel loops, follow through for proximal colon, enteroclysis for small bowel, and barium enema for colonic loops. These barium studies provide dynamic assessment of GI tract. We can see peristaltic movements of small bowel loops in real time under fluoroscopic guidance. But these procedures are very cumbersome for technician, also less tolerated by the patient. It is very time consuming and can cause some severe complications like peritonitis or fibrosis if it gets leaked through perforation or anastomotic leak. So nowadays there is very limited role of these barium studies except for barium swallow, which is used for primary evaluation of dysphagia, mainly at peripheral centers, and sometimes to see the integrity of surgical anastomosis, but it is done with water soluble contrast and not the barium. Enteroclysis is one special small bowel contrast study in which small bowel loop, either duodenum or jejunum, is intubated and contrast is given through this tube and not oral contrast. Advantage of this technique is it bypasses the stomach, so there won't be any delaying action at pylorus. So there will be better distension and controlled distension of small bowel loops. It also provides good dynamic assessment and mucosal details, but it is again time consuming and it does not provide information on mural pathologies and other adjacent extramural abnormalities. It also requires great degree of skill to perform as well as interpret these findings. So it is also declining due to availability of better methods. Modification of conventional enteroclysis is CT or MR enteroclysis, in which the initial procedure of intubation of small bowel will remain same. Contrast material is given through this tube, and when adequate distension of small bowel loops is achieved, CT scan or MRI with or without IV contrast is performed. It is also used when other imaging modalities have give inconclusive result. Now coming to most common radiological modality used nowadays, ultrasound of abdomen. It is easily available. There is no use of ionizing radiation. It is very fast and inexpensive modality. But it has also certain limitations, like it is operator dependent modality. Reliability of result depends on knowledge and skill of performer. There will be obscuration of deeper structure like retroperitoneum, deeper vessels and other organs due to overlap by bowel gas. In obese patient, there will be limited penetration of ultrasonic waves, resulting in poor acoustic window and suboptimal evaluation. And it also does not provide multiplanar reformation. Contrast enhanced ultrasound. It is a specialized and latest technique in sonography, mainly used for evaluation of focal lesion, most of the time for liver and occasionally for kidney. It involves intravenous administration of contrast material, which consists of microbubbles or nanobubbles of gas, after which ultrasound scan is done over few minutes, during which behavior of contrast material within the lesion is observed and resultant change in appearance of lesion is observed, and from which lesions are characterized. Generally, malignant lesion shows rapid uptake of contrast material and rapid washout. So they will appear as hypoenhancing or hypoechoic on delayed phase of scanning, while benign lesion shows gradual pulling in of contrast material within the lesion. So in delayed phase, they appear as bright or hyperechoic as compared to early arterial phase imaging. This is one sample case of focal nodular hyperplasia. Here we can see in grayscale image, only ill-defined area of subtle increased echogenicity is seen and mildly dilated adjacent hepatic vein. However, on contrast enhanced ultrasound scan, we can see a fairly well-defined bright echogenic nodule. We can also see a tortuous feeding artery and an enlarged draining vein. So this is the advantage of contrast enhanced study in ultrasound. Other advantages of contrast enhanced ultrasound is it uses purely intravascular agent. So there won't be any interaction with kidney or thyroid. There are very less chances of allergic reaction to this contrast material as compared to iodinated contrast used in CT scan. However, it is highly operator dependent modality, even greater than routine ultrasound, because it requires sound knowledge of normal and abnormal appearance of lesion and contrast material uptake after administration. It is also more expensive, almost comparable to CT scan, and it provides only targeted information about the lesion. The broader idea which we can get in cross-sectional imaging is not possible. Another latest diagnostic modality in sonography is fibroscan, or in radiology it is also called elastography. In this technique, mainly in GIT, this is mainly used for assessment of liver fibrosis. This video is demonstrating the method of fibroscan. It involves localization of good acoustic window, so there will be good penetration of ultrasound waves. Then sampling is done at appropriate depth. Multiple measurements are taken at different regions, and from reference standard, these results are compared with reference standards to assess the fibrosis. It basically involves estimation of stiffness or elasticity of tissue. Now coming to cross-sectional imaging modalities. The most commonly used cross-sectional imaging modality for GIT is CT scan with or without contrast material administration. It provides three-dimensional view of pathology with multiplanar reformation capabilities. Compared to ultrasound, it is operator independent. It gives superb anatomical detail and has high diagnostic specificity as it involves direct visualization of pathology. It also identifies other associated changes and complications due to main pathology, which will help in guiding the line of management. And images, once acquired, can be reviewed at any time after single scan. It is also helpful to assess the vascular tree of abdomen with its anatomical variation, which help in surgical planning. In case of ischemic changes, it will show cause of vascular narrowing, level of narrowing, whether the narrowing is complete or incomplete, and duration. either acute or chronic. And there won't be any overlap by bones or bowel gas in CT scan. Virtual colonoscopy can also be performed with CT scan by use of dedicated software packages. Advantage of this technique is it allows visualization of smaller polyps which might be missed on routine contrast CT scan. But as compared to actual colonoscopy, it won't allow sampling. There are very few contraindication or limitation to contrast enhanced CT scan. One is deranged renal function, and another is history of severe allergic reaction to contrast material in past, in which case one has to use alternate modality or can do plain CT scan. Now coming to another cross-sectional modality is MRI. It is not as commonly used as CT scan for GIT. However, it has some advantages over the CT scan, like excellent soft tissue resolution. Images can be acquired in multiple planes with different sequences, and it can also be performed in cases of deranged renal function, as it does not involve use of iodinated contrast. And recently, with availability of specific liver-specific contrast agents, we can do liver MRI only in MR. MRCP, magnetic resonance cholangiopancreatography. It is one of the most common MR study prescribed by gastroenterologist or gastrosurgeon. It is the diagnostic modality of choice to evaluate anatomy as well as pathology of entire hepaticobiliary tree and pancreatic ductal system. It gives very high resolution 3D images with availability of post-processing like maximum intensity projection, volume rendering, and there won't be any overlap by bowel gas and no issue of ionizing radiation. As I said earlier, with availability of liver-specific or hepatobiliary reticuloendothelial specific contrast agents, trend of liver MRI, contrast-enhanced liver MRI is increasing. In this technique, dynamic MRI is performed after intravenous administration of specific contrast agent, and images are acquired in different phases when the contrast material is in blood full or tissue phase, and these images are assessed for change in appearance of lesion over the time. From these images, results are interpreted and lesions are characterized. Here we can see there is persistence of enhancement on delayed phase images in case of focal nodular hyperplasia, while in case of hepatocellular carcinoma, there will be rapid washout and lesion will appear as hypoenhancing, hypointense on delayed phase images. Advantage of contrast enhanced MR as compared to contrast CT is it can be used in person with history of iodine reaction and with borderline impaired renal function because it does not damage the kidney. But it has some disadvantages also. One most common problem we encounter while doing MRCP or MRI of a liver is motion artifacts. It requires much more patient cooperation than any other modality because movement artifact will significantly deteriorate the image quality and can result in inconclusive study. Metallic implants and calcification can also give susceptibility artifact and obscure adjacent deeper structures. It requires relatively longer procedure time, difficult to perform in claustrophobic patients, and presence of pacemaker is an absolute contraindication.
Last 2 minutes.
ERCP is highly sensitive and specific technique for detection of CBD and MPD calculi and stricture. Advantage over MRCP is it allows sampling and therapeutic advantage. Its limitation is invasive nature and it doesn't give information about extramural pathologies and other adjacent organ. Now in very brief about these two nuclear scan. HIDA scan, it is hydroxyimmunodiacetic acid scan, and GI bleed scan. HIDA scan, also known as cholecystography, it is used for assessment of anatomy and function of biliary system, in which technetium-99 labeled immunodiacetic analogues are injected. Most common indication for this HIDA scan is to detection of biliary atresia in units, in which there will be good hepatic uptake of radiotracer, but it won't be excreted in bowel loop up to 24 hours. Now, bleeding scan is used to detect GI bleed, and it helps in determine the bleeding status, whether it is active or intermittent, and its gross localization. Material used for this bleeding scan are technetium-99 labeled RBC and sulfur colloids. Sulfur colloid is relatively less used because it has shorter half-life, while RBC has longer half-life, allowing longer evaluation time. So concluding the topic, in current scenario, older methods like X-ray has very limited role for primary evaluation of some of the pathologies. Ultrasound is most commonly used method for screening, and many times it found conclusive. But CT scan is best program solving modality. Although it is expensive as compared to USG, it gives very much broader detail about pathology, especially in positive cases and in older patients with comorbidities. Chances of recovery improve with early diagnosis and treatment, so one should not hesitate to go for CT. In this regard, I want to share these two cases which I have seen recently. This is a middle-aged female patient with severe lower abdominal pain and elevated CRP. Patient was undergone USG for 2 times at periphery, and it was inconclusive. Consultant called me and asked for export USG, but we discussed and later on decided to go for contrast enhanced CT. And what we found was large air and fluid filled collection with forming wall in pelvic cavity, pouch of Douglas, and along the sigmoid mesocolon. It was due to ruptured sigmoid diverticulitis. So with whatever expertise, I may not be able to find this in USG. And another case is 80 years old male with 2 episodes of acute abdomen in 1 month. This patient also has undergone USG for twice. Last USG was done by me only, and we were able to find only mildly dilated bowel loops. On subsequent CT scan, we found this stenosing growth at rectosigmoid junction, which is the cause for obstruction. So I want to highlight that CT scan is the best diagnostic tool in problem solving cases, and when there is inconclusive results for other modalities, or when there is discrepancy between USG and clinical findings, one should go for CT. Thank you.
Thank you, Dhaval bhai. A single question we can take at this point of time. Kamani sir.
This is not a question, but this is comment. Dr. Dhruv Desai agree with me, is a pediatric gastro. Pediatric patients comes with central abdominal pain, before consulting to us, they goes to general physician, they prescribe ofloxacillin. They went to pediatrician, they prescribe another medication, probiotics. We do X-ray abdomen. We are not interested in air fluid level or perforation, gas in the diaphragm. Almost all that time, this is loaded with stool. So entire colon is loaded with fecal matter. So just we give laxative and relative, and patient get relief. This is my comment. Do X-ray abdomen standing in pediatric cases. Almost you come to conclusion of cause of abdominal pain.
Thank you. I request Dr. Ghanshyam Jagani sir and Balda sir to please come forward for felicitating Dr. Dhaval. For the next lecture, I request Dr. Tushar Budwani. He is the intensivist at Prime Hospital. He has more than 10 years of experience in intensive care, and is going to give talk on a very important topic, nutrition in ICU, when, what, why, how, and how much. A topic which is very important but probably missed by many of us at times. Dr. Tushar, I welcome you here.
Thank you, Paras bhai. A very good morning to all of you. Today I am going to present a very important topic, nutrition in ICU. Yeah, no, just Tushar. Yes. This topic is very close to my heart and also my stomach. And you must be surprising why the nutrition in ICU is being presented by an intensivist. So an intensivist is always take care of the nutrition, and it's an it's most ignored and kind of neglected topic in the ICU. We always give more importance to antibiotics, vasopressors, steroids, other antifungal, but we don't give importance to our nutrition. Why this nutrition is so much important? What if we don't give nutrition to a patient? What will happen? Let me tell you, if any patient admitted in the ICU, after 48 hours, he is going to be malnourished. It definitely is going to malnourish regardless of whether he was well, he was not well, he was taking orally, he was not taking orally, whether he was having fever, whether he was having diarrhea. No. Any patient who is getting admitted after 48 hours in the ICU, he is going to be malnourished. And why it is important that we need to care of this nutrition? So we are going to discuss about when to start, how to start, why it is important, what are the contraindications, disease specific things that we need to take care of it. So any patient who comes in the ICU, they are in the catabolic state. So why its catabolic state is important? Because this catabolic state will increase the risk of SARS, and also it will lead to complications like increased chance of infection, it will increase the morbidity, it increase the multi-organ failure, high chances of weaning failure, high chances of staying on the ventilator, high chances of infection, and also it's going to end up with the multi-organ failure. So how this adequate nutrition is going to help them? So it will attenuate this metabolic response to stress, and it also favorably modulates the immune response. And hospital in that sense, it will reduce the hospital stay also, and overall better outcome. So this nutrition is very, very, very important, and we have to give as much as important to like other part of critical care management. Now, how will you assess the patient's nutritional status? So it is an indirect calorimetry test. I have never seen it. It's written in the book. That's why I'm telling you it's the best method. But you need a specific machine for that, and it's also very costly. So give importance to history. Whether patient is having chronic renal failure, chronic liver failure, whether patient was having any congestive heart failure, whether patient is having any cancer, patient is receiving chemotherapy, other comorbidities. Always look for the whether patient has a weight loss in the past few months. These are the patients who are at high risk of malnourishment. And also whether patient was taking orally well or not, patient was having vomiting, diarrhea. This we need to take care in mind before planning for the nutrition. We always have to plan for the nutrition. So when to start? As early as possible. But it doesn't mean that the patient comes, just comes in the ICU and we need to give him. Now, અમે ઘણી વખત એવા જોતા હોય પેશન્ટ એમ એમઆઈ સાથે આવ્યું હોય અને બીજું કંઈ તેને તકલીફ ના હોય, સાહેબ જમવાનું ક્યારે થશે? તો એ generally ત્યારે we can wait. So always start as early as possible, but when patient is stable. Okay? First, and this is very important, I need to emphasize on that. Do we need to check bowel sound before starting enteral nutrition? No, we don't need to check bowel sound before starting enteral nutrition. 30 to 70% of the patient who are getting admitted, they won't be having bowel sound. But that doesn't mean that his bowel is not working well. Bowel sound is just an indicator of contractility. It's not going to show you whether patient is having good barrier function, whether his absorption capacity is good, whether his elimination capacity is good, whether his immune mechanism is good. No, it's just an indicator of contractility. Okay, so you don't need to check bowel sound to start enteral fits. Hemodynamic instability in shock patient. Never ever start any enteral nutrition when patient is in a shock. Always first resuscitate him. If it's getting settled down, If vasopressors are coming down, patient's acidosis is improving, his urine output is improving, hypoxia is improving, acidosis is improving, then and then you start after stabilization and also 24 to 48 hours after stabilizing the patient. Okay, never ever start enteral nutrition when patient is in shock. It's going to cause mesenteric ischemia and ultimately lead to mesenteric infarct. Okay, so never ever start this feed in a hemodynamic unstable patient. And always plan out if how much we are going to give. We are going to start with this and we want to end up with this. So it's a gradual process. It's not like that you have to give nutrition on a very first day in a full amount. You need to give full nutrition, full protein on a very first day. No, it's not required. You just have to give on over a period of time, 5 to 7 days. Hemodynamic unstable patient, we already discussed it. How much? We have to deal only with the calories and the protein. Not apart from this, no. Calories, how much calories? Then 20 to 35 calorie per kg per day. These we need to give per day. And protein. Protein, how much protein? In critically ill patient, 1.2 to 2 gram. And in a trauma or CRRT patient, we give it higher because there is a high loss of the protein. So it's 2.5 gram per day. Never ever consider protein as a energy source. Only carbohydrate and fat. Consider this as an energy source and for the calories. And 70% calories should come from carbohydrate and 30% from the fat. Now we have decided that we are going to feed this patient, and so which route? So if gut works, use of it, and if not working, make it work. If patient is having paralytic ileus, if patient is having intestinal obstruction, if patient is having upper intestinal like gastric outlet obstruction, so make it use by giving a stoma, by putting a stoma, and make it use. Always use gut if it is working. If it not work, please make it use. Now, if we have decided that we are going to feed him with the enteral route, then the oral is the best way. If patient is able to take orally, then it's okay. If it is not able to take orally, then put a rice tube within 24 to 48 hours and meet our nutrition goal. NG, then NJ. NJ has some indications, we'll discuss about it later. PEG and FJ. Parenteral only and only if you are not able to feed your patient within 7 days, then you start with the total parenteral nutrition. Otherwise, just avoid it. Avoid it. And combined, there is no role of giving combined nutrition. Parenteral means through central line or peripheral line, and enteral through using your GI tract. Enteral, why enteral is important and it is better than parenteral? So it is a more physiological and it's less costly, and it reduces the surge also. It will decrease the translocation of bacteria, decrease chances of sepsis, decrease mortality, and it's proven then if you give enteral nutrition compared to parenteral nutrition, it will definitely reduce mortality. So always go for enteral nutrition. Don't be hesitate, don't be in hurry to start parenteral nutrition ever. Now, questions comes whether we need to feed continuously or intermittently. So there is no difference in as such in outcome, but I would definitely prefer that give it the bolus because it's more physiological. And what will happen? Nurse will make a feed, and it will he or she will go to the patients. Once you start with the continuous drip, he or she will not go to the patient, and it will just like it will going on 24 hours. So if patient is not tolerating bolus, then I would go for the continuous enteral nutrition. Now nasogastric or nasojejunal. So nasogastric, we all know that it's easy to insert, anybody can insert it, it's more physiological. And I would emphasize over here that how to confirm position. So I always prefer to do a chest x-ray and abdominal with upper abdomen cut to finalize and to confirm the position of the Ray's tube. This thing will happen that Ray's tube will go into the left lower lung, and you will find auscultation. By auscultation, you will find there is a bubbling sound is there, but the tube must be in the left lung. So always go for a chest X-ray with upper abdomen cut to finalize, to confirm the position of the Ray's tube. This misplacement occur only once in a life, but it would be lethal for the patient. So always go for a chest X-ray after putting Ray's tube. Nasojejunal, when are we going to put the nasojejunal tube? So when patient is having high gastroresidual volume, when patient is having high chance of aspiration with gastric outlet obstruction, gastric or duodenal fistula, severe gastroesophageal reflux. But what is the problem with this? Why we don't prefer? Because we need a skill, we need a scope, and we need a gastroenterologist. And we need to phone, we have to phone them in the night. Please, sir, come and put a nasojejunal. It's not a practical thing. So always go for a nasogastric, and there is no as such outcome difference. Yes, nasogastric is a little bit high for the chances of aspiration is high, but it's not going to cause any change with the length of stay or mortality and morbidity. Okay, so always go for a nasogastric. If the other indications are there for the nasogastric, yes, you can go for a nasojejunal. Now this is also very important. Which feed, scientific feed or kitchen feed, blenderized feed? We intensivists always go for a scientific formula because we read, I think, a little bit more. And others, I think we have always argue with the other doctors that go for a kitchen feed. So why not kitchen feed and why only scientific feed? So kitchen feed, we don't know about the kitchen feed, whether it is going to give us a particular amount of calories and protein. We don't know. Makka pani, water, juice, something like that. Whether this is going to give enough nutrition and calories to the patient, no, we really don't know. Another thing which is the problem with the rice tube, with the kitchen feed, because we don't know about the hygienic status. There is a high chances of contamination is there. So avoid kitchen feed as possible, if possible, because, and other argument is always there, the cost. If you see the cost would be around 600 per day for a patient who is, we are giving nutrition and calories. But if you consider, if you see that any fruit juice and the time we are spending behind in the kitchen, one person is there and he or she is in the kitchen only, he is not able to take care of the patient, and we are just spending times and money. This is right now, this is in these days, it's not easy to find out cheaper saag bhaji, vegetables and juice. So it is going to cost you around at least 400 to 500 rupees, 400 to 500 per day. So rather than go for this, make it easy. Just we have to just take a water and we have to add scientific formula in it and we have to just feed it. So you can take care of the patient also. The patient relative can take care of patient and they can save their times. So always go for a scientific formula because it's predictable. We know that how much energy we are giving and how much protein we are giving. So that is the most important thing because we know that how much we are giving. Now this is also very important, monitoring tolerance and adequate GRV. See, anything can happen. So if I ask a patient, if we ask a nurse whether patient is tolerating feed or not and whether you are giving it or not, so he'll say, sir, we have stopped it. Why? Then he'll say, sir, there was aspiration was there. Well, how much? Because 100, 150 ml. Well, 150 ml is not a value, it's not an amount that you need to stop RT feed. Okay, this is a very misconception by the staff and other doctors that we need to, if anything comes, then any fluid, any RTS period comes, we need to stop feed. No, it's a wrong thing. Don't do ever it. And we always, if you put a rice tube in me right now, so you will find 100 ml of RTS period. So it's a very common to have RTS period. Don't go for only gastric residual volume. Okay, always look for the another signs of intolerance, like patient is having nausea, vomiting, abdominal pain, abdominal distension. So always go for that. If patient is increasing, metabolic acidosis is increasing when you are feeding it and other parameters are okay, look for whether patient is intolerant, whether patient is not tolerating the feed. So never ever go for only gastric residual volume. We can go for, we can accept 300 to 500 of gastric residual volume. Okay, and before starting feeding, before stopping feed, we have to make it that we can give prokinetics, we can make a propped up, and we can control, we can electrolytes imbalance, we have to manage it. So before stopping RT feed, always look for the another reason and make it work and try to reduce gastric residual volume. If it is less than 300, you can also put it back because it contains high amount of acids and enzyme, which is very, very important for the digestion. So You can, if, don't discard it. If it's less than 100, and if it's not blood stain, you can put it back. Diarrhea, complication, what are the complications? Diarrhea, this is the most common complication. Anything happens to the patient, any diarrhea happens, we just stop the right feed. No, never ever do it. Just find out the other cause. It could be infection, it could be drugs, lactulose is going on, cremafin is going on. So never ever blame RT feed for the diarrhea. Always look for the another cause. Continue with the RT feed. Metabolic acid ischemia, yes, if patient is having in a shock. Aspiration, it's always been there, and misplaced MG tube. These are some of the complications which is very rare. Now, disease-specific enteral nutrition. Do we need to reduce protein in a patient with the acute renal failure, acute liver failure, chronic liver failure, acute pancreatitis, diabetes? Is there any specific formula? No, there is no need to give a specific formula. If we just need to concentrate on the calories and the proteins, we need to give proteins and calories, protein even in a patient with the acute renal failure, CKD, acute liver failure, chronic liver failure. We must give protein to these patients, okay? If hepatic failure, calculate dry weight for the protein and calories as patients are having ascites and edema. There is no role of branch chain amino acid in the patient with the encephalopathy who is receiving already first line luminal antibiotics and the laxatives, okay, like in the lactulose. There is no need for specific formula. The requirement for the nutrition remains same, calories same, protein same. Acute kidney injuries, as I told you before, there is no need of reducing protein intake. If patient is on a CRRT, give high amount of protein because there is a high loss of protein. Okay, so it's around 2 to 2.5, which is significant higher amount of protein you need to give. Yes, if patient is having high potassium and patient is having low EAF, then you need to restrict fluids, and also you need to restrict potassium supplement. Then this specific formula can come into picture and you can give it. Otherwise, there is no need of giving any specific formulas. Traumatic brain injury, start as early as possible. This I want to emphasize, anti-glutamine. There is only role of enteric glutamine only with the trauma and the burns and the post-surgical patient. Parenteral glutamine, there is no role, there is no evidence that it is helping the patient. Only enteric glutamine is helping the patient. Okay, and it may help. It's not like it's helping, it may help. Diabetes, no need of special formula. You don't need to give diabetic care. Acute respiratory failure, you don't need to give high fat or low protein carbohydrate formula. There is no evidence that it is going to help the patient. Sorry. Okay, thank you. This is all I think. Any questions, please?
Thank you, Tushar bhai. If there is any comment, question on this, a nutrition part well covered, the most important part. To felicitate Dr. Tushar, I request Dr. Sunil Popat sir and Dr. Atul Hirani sir to please come on the dais for doing the felicitation part. For the next talk, we have Dr. Dhruv Desai, is first pediatric gastroenterologist of Rajkot. He is currently practicing in the team Prime, and he has been trained extensively in field of pediatric gastroenterology. What he is going to discuss today is when to refer a child to a pediatric gastroenterologist, a very important topic, and I request Dr. Dhruv. He is a fellow in pediatric gastroenterology and hepatology from Sir Gangaram Hospital, Delhi. First and exclusive pediatric gastroenterologist and hepatologist of Saurashtra and Kutch region.
Thank you so much, Paras bhai. Good morning to all. Now, when this CME was being planned, I was asked about the topic, that what topic do you want to speak on? And I decided that moment that I want to speak on when to refer a child to pediatric gastroenterologist and hepatologist. The reason being that whenever I go to meet doctors, they will listen everything and then they will ask that, okay, what are the conditions that I should send a child to you? So basically, that's why I am presenting on this. Secondly, I have done a case-based presentation so that it makes interesting for all of you, as well as I am trying to keep it very small so that I can present as much as indications as I can. So without wasting much time, case number 1, there was a 13-year-old male child, came with history of tiredness since 3 months, occasional pain abdomen. There was no other complaints. So the general practitioner did the preliminary investigations where the child was found to have an hemoglobin of 5. So immediately the child was referred to an hematologist, where further investigations were done and child was found to have microcytic anemia. No other cause or possibilities were found. Luckily, TTG IgA was done, which was 650, and the child was referred to me. There was no significant past or family history. On examination, height, weight was normal, except for the pallor and mild tachycardia. Rest of the examination was normal. Provisional diagnosis, obviously for the high TTG, it was celiac suspect. Upper GI endoscopy was done, which was suggestive of D2 scalloping. You can see the furrows quite clearly in this. Biopsy was taken, which showed villus atrophy. Diagnosis of celiac disease was confirmed. Treatment with gluten-free diet, vitamin and iron supplements were started. 2 months after taking the treatment, the child is now improving. Hemoglobin is gradually increasing. Coming to case number 2, 4-year-old male child came with history of not gaining weight and height since last 2 years. Recurrent pain abdomen, occasional loose stool, recurrent URTI and viral infections. Investigated and treated with antibiotics and other supportive treatment many times. On investigation, revealed anemia with occasionally raised CRP and vitamin D insufficiency. TTG was done and it was 350. No other significant past or family history was present. On examination, the weight of the child was very low. It was only 9.4 kg, which was less than third centile. Height was also 85 centimeters, which was less than third centile. Pallor was there, rheumatic rosaries was there, bowing of legs were present. There was mild tachycardia, otherwise systemic examination was normal. Again, the diagnosis of celiac suspect with rickets. Child was investigated, was found to have vitamin D of 7, high alkaline phosphatase, low serum calcium, low serum phosphorus, microcytic hypochromic anemia with HB of 8. So all suggestive of again celiac. D2 endoscopy was done and again scalloping was present. Biopsy confirmed villus atrophy. It was celiac disease with rickets, and gluten-free diet with vitamin D, calcium supplements were started, and the child improved. So what I want to say from these 2 cases is that the celiac can present in various ways. First, as you see, height, weight was normal. There was only anemia. The child was pretty much asymptomatic. The second was child not gaining weight, height, was pretty much failure to thrive, malnourished, and it can also be celiac. So any child which present with recurrent abdominal pain, intermittent or chronic diarrhea, failure to thrive, not gaining weight, short stature, unexplained iron deficiency with microcytic hypochromic anemia, vitamin D deficiency, rickets, or even chronic constipation and vomiting should be evaluated with TTG IgA, and if found high should be referred to a pediatric gastroenterologist. Coming to case number 3, a 2-month-old female child came with history of regurgitation and vomiting after each feed, irritability after having feeds, frequent colicky episodes, not improving with symptomatic treatment and positional therapy. Frequent episodes of noisy breathing with occasional rash on face and body also were there. Child was on exclusive breastfeeding. There was no significant maternal, family or birth history. Birth weight of the child was 2.75 kg, current weight was 2.3, so there was decreased weight gain. On examination, child was active, not irritable, vitally stable. There were few rashes which were present on the cheeks, and systemic exam was also relatively normal. So my first suspicion was CMPA, that is cow milk protein allergy suspicion. The child was put on diet trial, and as the child was on exclusively breastfeeding, milk and milk products were banned from mother's diet. And this resulted into dramatic improvement within 15 to 20 days of diet elimination, and child started improving, regurgitation reduced, colicky episode reduced, and the child started to gain weight adequately. Case number 4, a 4-month-old male child, on and off loose stool since 2 months, occasional vomiting since 2 months, perianal redness since 1 month, blood in stool 3 times in last 7 days. The child was on top feed with regular formula milk. Child was given trial of cow milk even with in 15 days back. Treated with antibiotics, probiotics and other symptomatic treatment but not improving. And child is gaining weight adequately. Again, no significant past or family or birth history. On examination, normal CBC CRP was there. USG abdomen was done, which was normal. But stool routine showed mucus presence and occult blood was present. So again, this is a case of CMPA suspect. Again, two different presentations of CMPA. And as the child here was on top feed and not the breastfeed, the child was put on exclusively hydrolyzed formula, especially which comes for CMPA kids, and the child started to improve after 15 days. So milk protein allergy is an important aspect, particularly in infants, where they usually present with excessive colicky episode, excessive regurgitation or recurrent vomiting, discomfort after feeding, recurrent or intermittent loose stools with perianal rash. Recurrent skin rash or urticaria can also be a presentation of cow milk protein allergy, blood in stool, or recurrent running nose, noisy breathing, or wheezing. So all these things in an infant, if encountered again and again, the child should be evaluated for cow milk protein allergy and failure to thrive. So coming to case number 5, a 9-year-old male child came with history of loose stools since last 3 to 4 times in a day since last 4 months. Occasionally mild abdominal pain, 4 to 5 episodes of blood in stool. There was no complaints present. Child was evaluated outside where pus cells, mucus and occult blood was present in stool routine. CRP was 45, HB was 7.8, total count and platelet were within normal limit. So considering this as a case of dysentery, the child was put on oral antibiotics, other supportive measures. The child improved partially but not completely. So again, after few days, complaints of loose stool and blood in stool recurred, again evaluated, found to have CRP of 35, stool routine same, pus cells, mucus, as well as occult blood. Hemoglobin further dropped to 6.8, total count and platelets were still normal. The practitioner had done a CECT abdomen where an ileocecal thickening was present and he suggested this could be a tuberculosis, and ESR was done which was 51. So the child was put on antibiotics and ATT was started and along with the supplements. ATT was continued for 1 month, but there was no improvement in symptoms. So the ATT was discontinued and the child was referred to me. There was no significant past or family history. On examination, child was conscious, cooperative, pallor was present, otherwise systemic examination was relatively normal. My provisional diagnosis was either IBD or tuberculosis. So further investigated the child. Child had CRP of 81, ESR of 57, HB further dropped to 6.4, TLC of 12,000, platelet of 4.6. Fecal calprotecting was done which was 175. And stool routine still, mucus was present, OB was present with few pus cells. So we did the colonoscopy of this child and areas of patchy granularity, few ulcerations were present, mainly in ascending and descending colon, ascending and transverse colon, ileum, descending colon, sigmoid and rectum were relatively normal. Biopsies were taken for histopathology which suggestive of cryptitis and cryptasis, which were suggestive of inflammatory bowel disease. The final diagnosis of undifferentiated IBD was made. The treatment was started with mesalamine and other supportive measures. After 1.5 months, the child is now better. There is no blood in stool, there is no pain abdomen, and child is actually doing fine. Case number 6, a 6-year-old male child, known case of chronic ITP, had an history of planeless bleed per rectum 2 to 3 times. There were no other complaints. Occasional constipation history was present. The PR was done by a surgeon where he was found to have normal examination. CECT was done and it was suggestive of query polyp. So it was referred to pediatric gastroenterologist. On examination, HB was 7, platelet was 48,000, PT, INR and rest of the reports were normal. On examination, except for the pallor, examination was normal. Treatment, initially the patient was stabilized with Dexona and IVIG. Repeat platelet count were 1.68 and then the child was taken for colonoscopy with polypectomy. 2 polyps were observed and polypectomy was done. So again, bleeding PR, an important entity where a child should be referred to a pediatric gastroenterologist. It can be due to rectal polyp, it can be due to fissure, can be due to IBD, allergic or milk protein allergy, it can be due to Mickels, can be due to infective causes. So the child should be referred to a pediatric gastroenterologist. Coming to case number 7, a 17-year-old male child had jaundice since last 2 months, itching over the body since last 1 month. Initially, child had fever for 4 to 5 days along with pain, abdomen, decreased appetite. Child was investigated outside where there was a classical picture of hepatitis A. After 15 days, in view of persistent jaundice, the child was again investigated where there was persistent transaminitis and the bilirubin raised drastically from 7.4 to 29. So the child was referred to me to further investigation. There was no significant past or family history. Child was pretty much conscious, cooperative. Other than icterus, there was no finding present in the child. There was no complaints of pain, abdomen, there was no fever, nothing. So the provisional diagnosis of hepatitis A with prolonged cholestasis was kept in the mind. Treatment was started with ursodeoxycholic acid with essential supplements. On further investigation, the transaminitis was reducing, total bilirubin was reducing. To rule out autoimmune hepatitis, IgG was done, which was relatively normal. Even the ceruloplasmin was normal. HAV was done, which was again weakly positive, a sign of prolonged hepatitis A hepatitis. PT-INR was normal. USG abdomen was suggestive of mild changes of hepatitis. So the child was stable, accepting orally, except for the jaundice, there was no complaints. So the diagnosis remains the same. Now for the second opinion, child went to Ahmedabad, where further investigation were done, where autoantibodies were normal, liver biopsy also was done, which was suggestive of only hepatitis. So the diagnosis remained the same. Child came to me for the follow-up. I continued him on the same treatment, and LFT was normal after 4 months of starting the disease. So hepatitis A, though very common, very simple to manage, self-limiting, but can result into cholestatic hepatitis, relapsing hepatitis, autoimmune hepatitis, fulminant hepatic failure. Yep. So 1.5 months old female child, jaundice since last 15 days, no other complaints, breastfeeding and gaining weight. On investigation found to have direct hyperbilirubinemia, referred to me without wasting much time. There was no significant other history. On examination, icterus was present and hepatomegaly was there. There was no, the provisional diagnosis of neonatal cholestasis was made with query EHBA. Further investigated where fasting USG abdomen was done, which showed query normal. So we were not sure what was the cause. So liver biopsy was done where it suggested extrahepatic biliary atresia. Final diagnosis made in a timely fashion, referred to pediatric surgeon, and Kasai operation was done within 60 days of life. Again, a 5-month-old child, jaundice, abdominal distension, bruising on abdomen. Child had evaluated outside multiple of times where bilirubin was found to be varying between 5 to 7. Lastly, the last one was 8.2. Other investigations which were done was HbSAg negative. Parents were uneducated, repeated counseling was done to take an opinion of pediatric gastroenterology, but they came after 5 months of age. The child was on exclusive breastfeeding, not gaining weight since last 2 months. Parents were not sure whether the stool was white or yellow. On examination, there was dilated veins present over the abdomen. Hepatomegaly was present 2 centimeters below. Bruising spots were present. So all indicating to CLD development secondary to EHBA. On further investigations, the child was found to have CLD, so liver biopsy was not possible. HIDA scan was done and it was found to have non-excretory, so EHBA was finalized. But here we cannot do Kasai operation because already CLDA has been developed, so child was counseled and guided for live donor liver transplantation. So again, a very important topic of neonatal cholestasis, where the child should be referred if has jaundice beyond 15 days of life, conjugated hyperbilirubinemia, recurrent or prolonged unconjugated hyperbilirubinemia, or with abdominal distension, hypoglycemia, bruising, white stool, IUGR, failure to thrive, or facial dysmorphism. Coming to my last case, this is 18-month male child, foreign body ingestion of glass or mirror used for the pot decoration. There was no vomiting or pain abdomen. Ingestion was 1 hour prior, referred timely by a pediatrician by giving the advice that there is nothing to be given by per orally. Examination was within normal limit. Endoscopy was done, foreign body was identified and removed, and this was the foreign body. It was the glass which was sharp in all the way, so it was pretty much difficult to take it out. We had to put an over tube to take out the glass so that it doesn't damage the esophagus and everything. So these are only few indications out of many for referring a child to pediatric gastroenterologist and hepatologist, but the key is timely referral. And thank you so much for patient listening.
થેન્ક યુ ધ્રુવભાઈ, ઇટ વોઝ એન એક્સેલન્ટ લેક્ચર. બાળક સૌથી પ્રેશિયસ વસ્તુ હોય ને એમાં તમે એમ કહો કે ડોન્ટ ઇટ વીટ, ડોન્ટ ડ્રિંક મિલ્ક, કે લીવર બાયોપ્સીની જરૂર પડશે. સો યુ નો ધ રિલેટિવ્સ ગેટ પેનિક, કે મમ્મી પપ્પા પણ પેનિકમાં આવી જાય, દાદા દાદી પણ થઈ જાય. સો એટ ટાઈમ અ પ્રોપર referral is needed, proper counseling is needed, and it's great that we have a pediatric gastroenterologist, exclusive pediatric gastroenterologist and hepatologist in our own city for this. So if there are any queries for that, we are happy to share 1 or 2 quick questions. Yeah, Kamani sir, expert comment from your side also.
Regarding first case, HB was 5.
Right, sir.
This child required transfusion or improved with IV iron?
Yes, the child was actually referred to me from an hematologist only.
No, HB was 5.
Yes.
With
So I discussed the case with hematologist, and he said it's fine, no need of transfusion is needed. First, let us make the diagnosis. So after the celiac was done, the routine iron supplements were given, sir. And the child is now improving after.
My question is, because small intestine proximal part involved, iron is absorbed from the duodenum.
Correct,
So
sir.
this patient having a low ferritin, we have to supplement IV iron. Number 1. Number 2, surgeons, 50% cases of intussusception is due to celiac disease because of mucosal abnormality.
Rahul Saib, any special comments from your side in this?
Really, because most of the time we miss the celiac diseases. Very rightly pointed out the current scenario. And celiac disease doesn't present only with diarrhea. They are non-diarrhea celiac also. There are so many infertility, weight, failure to gain weight, and they can present to any department, endocrinal abnormality. So we have to be very careful. Now celiac is rising in India. The only problem is we don't open our eyes because our mind doesn't know.
Regarding your IBD cases, it's I think fits into Crohn's disease because site of involvement, the way of fecal cal, so you can label as a Crohn's disease.
So thank you for the expert comments, and thank you for the very nice lecture, Dr. Dhruv. I request you to please come on the stage. I request Dr. Kasundra Sahab and Dr. K.M. Patel sir to please come on the stage along with Kamani sir and Dushan Bhai to do the felicitation. And now it's a pride and honor for us to invite the senior most gastroenterologist, first gastroenterologist of Saurashtra and Kutch region, Dr. K.K. Rawal sir, for his lecture. It's a treat to hear from you, Rawal sir, anytime, always. And he's going to speak on gastroscope or knife. He's doing the first US interventional endoscopies and everything in Rajkot. A big round of applause for Rawal sir and all you, sir.
Thank you, Paras. I welcome you all once again on behalf of Prime Team. I really thank Praful, Dushyant and Paras for giving us this opportunity. See, basically, I will discuss today the changing role of a gastroenterologist. We now do a lot of therapeutic endoscopy and advanced therapeutic endoscopy rather. I use my endoscope as a knife. I will show you how in next 10 to 12 minutes. This is also called advanced therapeutic endoscopy. This is basically flexible endoscopic surgery. અમે થોડું ઘણું સર્જનનું રોલ પ્લે કરી લઈએ છીએ. Of course, I am આમંત્રિત બધા સર્જનોને અમે જરૂરત પડે જ છે. But this is the changing scenario. You must know what we do. We are grateful to this great Indian. He's Dr. Pankaj Pasricha. He trained from AIMS Delhi, now in USA. He developed this endoscopic tunneling technique in pig model. Later on, Professor Inouye from Japan developed this POEM model in humans. We are proud of this Indian. These are the instruments we use for third space endoscopy. These are the high definition endoscopes with water jet functions. Then we have high definition improved cautery. Can I have the marker, please? Cautery. Okay, I think then we have water pump, and then lastly we have CO2. We don't use air in now day-to-day scopy. We use CO2. What pointer? Okay, this one. Okay, and this is the CO2 generator from the Olympus. And these are the endoscopic knives. These are the hybrid knives. These are the insulated tip knife, and this is my favorite TTJ knife, triangular tip knife with water jet functions. These are the hemostatic forceps to control the bleeding. We catch the vessels by these forceps like instruments, and then we apply the coagulation current, and immediately the bleeding is stopped. This is the distal attachment. I use this on the tip of the scope to keep the mucosa away from the scope and to have the nice vision. It also stabilizes my scope during the tunneling technique. This is how we pass the instruments through the endoscope. This is IT knife, insulated tip knife, and this is the co-grasper. Basically, we can pass two instruments in single endoscope. This I use in difficult cases. These are our clips, rotable clips. They open and close many times before the perfect positioning at the proper place. They are the sutures like amara mate aa taka chhe. This is very important classifications for us, which tells about the histological nature of any lesion. This is basically depending on the endoscopic features of a polyp. This is nice classification. This is type 1, type 2, and type 3. Depending on the histology, I mean endoscopic appearance, we can know this is benign or malignant. Now see, this is okay. This is a polyp in the colon, and this is when we apply narrowband imaging. This is a nice one. Now we don't take the biopsy. We just do it on this NBI imaging, and if it is benign, this is a hyperplastic polyp. We leave it. Don't do anything about this polyp. In white light, you can't make out whether this is what is the nature of the polyp. So we use advanced endoscopy system, NBI imaging, to make out the nature of the polyp. This is nice to adenomatous polyp. So this can turn into the high dysplasia and eventually into the cancer. So this has to be removed by EMR or endoscopic mucosal dissections without taking biopsy. Now we don't take biopsy in colonic polyps. This is on NBI. This is a high grade dysplasia. This is invasive cancer, so we cannot take out by endoscopy. I have to refer this to my surgical colleagues for surgery. Now this is a case. This is nice to adenomatous polyp. All nice to polyps are adenomatous, so they have to be removed. So we remove it by doing EMR, endoscopic mucosal resection. Inject, lift, and then cut. It takes hardly few seconds rather. It should not take more than 4 seconds, otherwise there is a chances that you have catch hold of the muscle. And then you inspect the scar for any bleeding, and immediately you can control any complication, perforation or bleeding can be immediately controlled. This is a case of 40-year lady who had a cancer of the esophagus limited to the mucosa. So we mark the lesion all around by the dual knife, and then we chip off the lesion. We dissect the lesion, we elevate the lesion by injecting the saline and indigo caramine, and then by dual knife it was sliced off underlying muscle. I use IT knife also. This is the IT knife, insulated tip knife, to prevent the perforations. And at last we inject, after dissecting, we inject steroids to prevent the stricture formation in this. And see, the major surgery, esophagectomy, could be avoided by endoscopic submucosal dissection. This is a case of early gastric cancer in the antrum. So without deeper invasion. So we mark the lesion 5 millimeter away. We mark the mucosa all around. Then I use dual knife to cut the lesion all around, circumferential dissection. And then it took me around 40 to 50 minutes to take out this lesion. You have to just prevent the muscle injury. That is very important. And after slicing this off the underlying muscle, we take out the specimen and send it for the histopathology. And lastly, when this is the last part of my cut, and this is the scar. You can see the scar, and then we close it by clips. This is a tumor in the rectum. This is, see if you can see this, this is nice too. So this has to be removed. This will eventually turn into cancer. So this is the endoscopic mucosal, submucosal dissection, ESD. This is a 56-year male presented for dysphagia for last 4 years, referred after failed balloon dilatation twice. We did manometry which showed type 2 achalasia cardia, and barium showed the hold up of the column. So this is classical achalasia cardia. This was the endoscopy, and it was very tight lower esophageal sphincter. It was very difficult to pass the scope into the stomach. Achalasia cardia is very commonly missed in endoscopy. You have to be very careful about it. Any patient with dysphagia, you have to be careful. It is not functional. So we did, the standard of treatment of achalasia cardia is endoscopic POEM, per oral endoscopic myotomy, which is better than balloon dilatation and even surgery in type 3. So this is the 4 steps: mucosal incision, submucosal tunneling, myotomy, and then the clip closure. This is the esophageal lumen. This is the esophageal lumen, and you see very tight esophageal sphincter. We could not pass the scope inside. Then we inject the mucosa with a mixture of saline and indigo carmine about 10 centimeter above the LES. Then we give an incision. This is the IT knife. You see the incision. તમે મારું incision જો કેટલો clean and sharp છે. This is like we are using a surgical knife. You see, there is no bleeding absolutely because of improvised cautery. This is the incision what we give. And then we go into the submucosa, we dissect. This is the submucosal tissue. We dissect it by using TTJ knife and spray coagulation current. This is dissected. This is the muscle layer, and I am showing the submucosal tunnel. This is submucosa and above is the mucosa. You have to prevent the injury to the mucosa. So by very fine skilled movement of your scope, you should prevent the damage to the underlying muscle and to the upper mucosa. So we dissect the submucosa, make a tunnel. Then this is the end of my tunnel in the submucosa, in the esophagus wall. અમે દિવાલમાં સુરંગ બનાવી esophagus ની દિવાલમાં. So after this I come out. This is long tunnel, submucosal tunnel inside the esophagus wall. Then we come into the lumen. Again I go deep into the lower esophageal sphincter and then into the stomach to see my tunnel has crossed LES or not. And this is the bluish discoloration of the mucosa, which tells me yes, I have crossed the lower esophageal sphincter, which is very tight, and that is causing the dysphagia. Then again I go into the submucosal tunnel. Now you see there is the high definition scope, so very clearly you can see the muscle. So this is the circular muscle. Then I cut it by TTJ knife, and I use always spray current. So this whole circular muscle is cut. Just above the LES, I start cutting both circular and the longitudinal muscle of the esophagus. So this is the circular myotomy. And once we cut this muscle, depending on the type of the achalasia, type 1, 2 or 3, we tailor our myotomy. In type 3 it is longest. This is the myotomy. You see I have cut the muscle on both the ends. And then again we come into the esophageal lumen. This is the esophageal lumen. And you see how relaxed the lower esophageal sphincter. So this is the very effective and long-lasting treatment of achalasia cardia by doing per oral endoscopic myotomy. And now the incision which was given on the mucosa is closed by the clips. This is the Olympus clips, the Chipia JV clips. These are the steel clips, and we apply, depending on the length of the incision, 3, 4 or 5 clips, and this is closed. And then we come out of the tunnel, and the patient is started orally after 2 to 3 hours, and next day in 12 hours patient is discharged. So this is the beauty of the poem. Now, how to control the bleeding? We also should know how to handle the complications. Complications are part of our life. Here during tunneling technique, see, there was a minor ooze. I tried to coagulate with my knife, but the bleeding was brisk. So we inject the water jet, told me where is the bleeding. Then this is the co-grasper. This is opening parallel. So I have to rotate it. There's a facility in this. You can rotate your co-grasper. This is the forceps-like structures. And then you catch hold of the blood vessel. Again, you flush with the water pump, and then you coagulate. We use soft current to seal this vessel. And immediately within seconds you see the bleeding has been stopped. You should also know how to prevent the complication. This is the perforation. The perforation is really a dangerous thing. You always should know how to handle it. And see that perforation was immediately closed by rotable clips. These are single use clips. You can rotate according to the position, and you apply the clips and you close it. Now even perforation of 2 centimeter size we can close by the clip or loop and clip methods. This is another interesting case. 60-year-old male presented with the dysphagia, and endoscopy showed an epiphrenic diverticula. Sorry. This is the epiphrenic diverticula. This is the esophageal lumen, and this is the diverticular lumen. This is the epiphrenic diverticula on the barium. What we did again diverticular poem. This is the diverticula, and this is the esophageal lumen. So again we injected the submucosa with indigo carmine, and then we went inside the tunnel. We did the submucosal dissection. You see, this is the diverticular lumen. This is the diverticular lumen. I exposed the lumen. This is the diverticula. And this is a very gentle, sensitive instruments. You can do anything you want. And this is the tunnel. We went, and this is the diverticular septum, which was compressing on the lumen, causing dysphagia. And then we cut the septum. This is called diverticular septotomy, D poem. And then we extended our myotomy till the lower esophageal sphincter also, because he had type 3 achalasia cardia also. And then we came out of the tunnel. This is, you see, the final cut. And this is the septum which cut, and then we applied the clip and close it like the poem. And see that this was the barium. This was before the septotomy, and this was after the septotomy. The diverticular disappeared and patient improved, discharged next day. This is again interesting case, second last case. This is patient presented with dysphagia. This is the diverticula on barium. So the diagnosis is Janker's diverticula. So we did again JED poem. JED poem is that we did the septotomy. We get injected with, this is the esophageal lumen, this was the diverticula. We cut the septum in between, and you see before there was a diverticula, after the diverticula disappeared, patient improved, discharged next day. This is my last case. 51-year male presented with diarrhea. Sigmoidoscopy showed a submucosal lesion obstructing the lumen. This was the CT scan. You saw this is the rectum. This is the rectal lumen, and this large tumor as reported GIST. This was 7 centimeter large tumor in rectum, and it was reported at gastrointestinal stromal tumor. And we did sigmoidoscopy. Sigmoidoscopy showed a large smooth submucosal tumor. I was confused because mucosa was absolutely normal. So what to do? You have to see, you have to do EUS. So we did EUS, and which showed a cystic lesion with gut wall signature. This is a classical of what? Classical of duplication cyst. This is very rare. I have seen only 4 cases in my life. So this was a very rare finding of duplication cyst. And then what we did endoscopic marsupialization. So we decided to do endoscopic therapy. We incised the cyst by the needle knife. and then you see this is through and through the whole wall of the cyst was cut, and the dirty fluid came out. This is the dirty fluid, and immediately the cyst collapsed, the wall became almost smooth, and then we did applied 2 clips to evert the edges so that it doesn't reform, and patient was discharged 6 hours after the observation. Thank you. So if there is any questions,
All are clear. Excellent work.
it means
Beautiful demonstration, beautiful videos. Thank you, Rawal sir, for the excellent lecture. I request Rawal sir to please stay back. I request President-elect Dr. Sanjay Bhatt sir and our GMC observer for today, Dr. Kirtibhai Patel sir, please join us for the felicitation part for felicitating Dr. K.K. Rawal sir. Thank you, Rawal sir, for the excellent lecture today. I request the next speaker is the young and dynamic Dr. Chintan Kansagra, who is specialist in pancreatic disease, IBD, specialist in endosonography, enteroscopy, ERCP, a great sportsman also. He's going to talk something about role of EUS in day-to-day practice today. So I request Dr. Chintan Kansagra to join us.
પારસભાઈ પાસેથી ઘણું શીખવાનું છે, એટલે હવે ધીમે ધીમે આઈએમએમાં એની અંડરમાં ટ્રેનિંગ ચાલુ કરી છે. લેક્ચર થોડું લાંબુ છે, પણ હું શોર્ટમાં પતાવીશ અને માતૃભાષાનો ઉપયોગ બને ત્યાં સુધી વધારે કરીશ. So what is EUS? Endosonography શું છે? તો કે it's a mixture of endoscopy અને sonography. પ્રોબ હોય ને એ એન્ડોસ્કોપીની ટીપ ઉપર હોય, સાથે સાથે એન્ડોસ્કોપીની ટીપ ઉપર આપણો રૂટીન કેમેરો તો હોય જ, એટલે બંને વસ્તુથી આપણે જોઈ શકીએ કે વેધર દેર ઇઝ એની લેઝર પોઇન્ટર. હા, જવાબ આવી ગયો. So whether there is one probe, endosono probe as well as the camera. So you can see endoscopy view as well as sonography view. And also there is a place from which our needle, endoscopic EUS needle, which you have seen in the first lecture, I'll again show you, that needle will pass and then you can take a tissue. You can do multiple procedures also. So it's a mixture of endoscopy and sonography. So EUS ME2 is the leading instrument of endosonography as of now, and it's like a recent generation iPhone only, and it's also costlier than 50 times costlier than iPhone. So sometimes you see last case which Rawal sir has shown, that you can see the lesion, but you don't know whether it's a cyst or it's what it is. The content is fluid, content is solid, whether there are any vessels. So these all things you can find out with the EUS. You can take a FNA cytology, FNA biopsy. So fine needle aspiration cytology and biopsy with it. You can reach the area which is nearby and take a tissue from inside only. So there won't be any external marks with the EUS. Also, it will prevent the track seeding. What is track seeding? જ્યાં કેન્સરના દર્દીમાં જ્યારે આપણે સીટીથી બાયોપ્સી લઈએ ને બહારથી, ત્યારે જ્યારે સ્કિનમાં જે જગ્યાએ પંચર કર્યું હોય ને એ જગ્યાએથી જો ટિશ્યુ ત્યાં ડિપોઝિટ થઈ જાય સ્કિન ઉપર, તો એ જ જગ્યાએ પાછો ગ્રોથ થઈ શકે સ્કિન ઉપર, વિચ ઇઝ કોલ્ડ ટ્રેક સીડિંગ. જ્યારે તમે એફએને લીધી છે ટ્રેક્ટ ઉપરથી, એ જગ્યાએથી સીડિંગ થાય છે. કેટલાક પેન્ક્રિયાટિક લિઝનમાં અને કેટલીક વખતે જ્યારે આપણે એન્ડોસોનોથી બાયોપ્સી લઈએ તો એ એરિયા આમે સર્જન જ્યારે સર્જરી કરશે ત્યારે રિમૂવ કરવાના જ છે. So then why not to take it from inside? So that's the also one more advantage which we have. And there are many applications for the needle also. Apart from the taking tissue, you can inject multiple things like alcohol in inject, you can alcohol, inject alcohol, inject fiducial. What is fiducial? ક્યારેક રેડિયોથેરાપી, ગાઈડેડ રેડિયોથેરાપી કરવી હોય તો એ લોકોને આખા ટિશ્યુના ફરતે એમને એક એક માર્કર આપવાનું હોય. એ માર્કર આપી દઈએ તો એ સેમ એ પ્લેસ ઉપર મશીન એની રીતે જ રેડિયોથેરાપી આપે, જેનાથી રેડિયોથેરાપીની ઓવરઓલ સાઇડ ઇફેક્ટ્સ ઘટી જાય. આ અમારી નીડલ એન્ડોસોનો નીડલ છે. એકદમ લચીલી નીડલ હોય અને નીડલ ની ઉપર શીટ હોય. આપણે શીટ સાથે પહેલાં અંદર જઈએ અને જેને પછી નીડલ આપણે ખાલી નીડલનો ભાગ આગળ મોકલીએ. અને શીટ શું કરે કે જે અંદરના ઇન્સ્ટ્રુમેન્ટને ડેમેજ થતું પ્રિવેન્ટ કરે, એટલે એન્ડોસોનોગ્રાફીનું મશીન આપણું ડેમેજ ન થાય. So there are multiple applications, high-end applications like EOS guided common bile duct drainage, which I will show you in my lecture. Gastric outlet obstruction, you can put the endosono guided stent inside, and you can make a GJ, gastrojejunostomy, which surgeons usually make surgically. We can do it endosono guided without any scar from outside. So in advanced biliary and pancreatic cancers also you can treat the lesion. You can do gallbladder drainage when patient is inoperable. When you can't operate the patient, just put the scope, pass it to antrum, find out the GB and just put needle in it and put the stent. You can also diagnose MRCP નું ધવલભાઈએ બહુ સરસ કીધું, but sometimes very small stone, 2 to 3 millimeter stone. You find that CBD is dilated, but you can't find what is there inside. So then in those cases also EUS. So એન્ડોસોનોથી આપણે બહુ નાના નાના સ્ટોન્સ પણ 2-3 મિલીમીટરના સ્ટોન્સ પણ ડાયગ્નોસ કરી શકીએ છીએ. So diagnostic roles in pancreatic cancer staging, mediastinal lymphadenopathy, suspected choledocholithiasis, just in case which we discuss. And also latest instrument we can do elastography with the EUS. Therapeutic roles like pancreatic fluid drainage, US guided biliary drainage, US guided GB drainage and celiac plexus neurolysis, drainage of rectal and pelvic abscess, is US guided gastric varices coiling. I'll show you this case. US tissue ablation, US guided angiography. This is very not in this is just the stage of study as of now. US guided botox injection, US guided gastroenterostomy is already been done routinely. Novel pre-procedure analgesia, anti-tumor injection therapy, anal sphincter dyssynergia. So mediastinal lymph node EUS થી શું કરવા લેવો જોઈએ? તો કે એ જ મેં સમજાયું કે ટ્રેક સીડિંગ ન થાય. બીજું, મિડિયાસ્ટિનલ લિમ્ફ નોડ અંદરથી જ્યાંથી લઈએ છીએ એ જો સેન્ટ્રલ લોકેટેડ હોય મિડિયાસ્ટિનલ લિમ્ફ નોડ તો એ ઇસોફેગસની જસ્ટ લેટરલી હોય છે. ઇટ્સ વેરી ઇઝી પ્રોસિજર ફોર એની એન્ડોસોનોલોજીસ્ટ ટુ ટેક અ ગુડ ટિશ્યુ. You can take beautiful biopsy tissue. You can do IHC staining on those materials and diagnose it properly. So linear EUS કરતા radial EUS થી diagnosis better થાય, but radial EUS have a limitation that you cannot pass needle. Linear EUS having both the diagnostic as well as therapeutic implications. So most of us use linear EUS, where field of view is just 160 degree, but you can do therapeutic. Radial EUS field of view is 360 degree. So surrounding you can also, it's just for the better for the diagnosis part. So subcarinal area lymph nodes very easily accessible from our scopes. There are significance like oncological significance, N2 if the right lung cancer and left lung cancer. And also sometimes we are not sure whether it's just the carcinoma, whether it's just carcinoma plus the or just tuberculosis. So in those cases also it's useful. So this is lymph node visible. Surrounding is the left atrium and right atrium. This is the subcarinal lymph node. And you can see they are all conglomerated lymph nodes, and there is loss of fat plane. This is the needle which is coming through it, and with this needle you can take a beautiful specimen. And with you can see this is kind of specimen which we generally retrieve from our US needle, and with this specimen our pathologists are very happy, and most of them they don't complain, and they can do even biopsy, and they can do histo diagnosis, as well as they give us IHC also. So centrally located lymph nodes, centrally located mediastinal lesion around the trachea, always prefer EUS over the endobronchial ultrasound. Endobronchial ultrasound is also one more modality which is not available as of now in our city, but it's available in I think Ahmedabad, one center. But most of the lesions we would be able to access is through endosonography. And there are only few indications where there is just the peripheral lymph nodes. So those lymph nodes which are not accessible rightly endosonologically, not centrally located, they would pass the endobronchial ultrasound and put the needle. So what is CT versus EUS? So in CT, when you take a biopsy, 10 to 15% chance of pneumothorax, cannot assess subcarinal and AP nodes. Track seeding and less sensitive method, CT is less sensitive than others. So next we are going to discuss the case. This is a case of 75-year male with the jaundice of last 1.5 month duration, intractable pruritus, pain abdomen, weight loss of 5 kg. US picture જોઈએ તો this is the common bile duct, and you can see the material inside. These are the material which is not having acoustic shadow, so this is not stone. So but there is some material inside the CBD. So what is this material, and why patient is having obstructive jaundice? So that's why we have to find out. And this material is not looking like stone, it's like more like a sand, more like a tissue, not exactly the stone, not exactly the lesion. Lesion mostly would be hypoechoic, this is isoechoic. So we did ERCP. ERCP showed that this is the material which is coming out. This is the hydrated cyst which was communicating with the common bile duct, and we removed the hydrated membrane, and muck and pus, everything came out. So પ્લમ્બિંગનું કામ કરીએ છીએ. અમારું પ્લમ્બિંગ અંદરથી થાય છે, યુરોલોજિસ્ટનું પ્લમ્બિંગ બહારથી થાય છે. This is such kind of plumbing work which we do with the ERCP. So we do treat the common bile duct therapy with the ERCP. This is the stone, very small stone. You can see the size. The size is around 2 millimeter. And CBD is very small. So this kind of small CBDs and stones would be mostly not picked up by MRCP. So this patient already underwent MRCPs, multiple episodes of pain abdomen, recurrent pain abdomen, and was not diagnosed. So undiagnosed pain abdomen, ખબર નથી પડતી શું છે, પણ pain abdomen છે. EUS is the one modality which will give you many answers in few cases. So studies have found out around 10 to 15% of the undiagnosed pain abdomen you can give diagnosis with the EUS. So then it's very easy. You pass the ERCP score, and you can see that it's such a small stone. This is very zoomed up view, but you can remove such stones ERCP wise. So this is one case of chronic liver disease with gastric varices, and had history of hematemesis. So this patient had, this is the EUS view, and this is the, one more time I have to use this. So this is the varices, gastric varices, which is protruding into the lumen of the stomach. And but also varices were more into the lumen of the GE junction than the protruding one. And this for this patients, what we planned is We injected the coil. Actually, wait. Wait, wait, wait. મારે છે ને ફોરવર્ડ કરવો છે વિડિયો, નથી થતો આમાં. વિડિયો પ્લે નથી. બેન બંધ કરીને પાછું ચાલુ કરશો. છોડો. ઓકે, ચાલશે ચાલશે એટલે હું જોઈ લઉં છું. So we injected the coils in this varix, and this is the post injection of the coil. Mostly we do endoscopic glue therapy, but when there is a lumen, you cannot see the extent of the varix in outside the lumen. This patient already underwent glue injection once, but then also patient rebleeded, so we had to take him up for the repeated session of EUS also, and we found that the lumen varix was there, but apart from the lumen, inside there was a varix which was not easily visible on endoscopic view, but the EUS view it was visible. So we injected the coil, and post coil injection, these are the coils which we have injected into the glue, and around the coil you see there is nice nidus formation and thrombus formation is there, and the patient was having relief from the bleeding. This is one more case of choroidicoduodenostomy, which we did EUS guided. So patient was having obstructive jaundice, and CT was showing head mass and 4 centimeter lesion in the head and neck of pancreas. So what initially, like any other case, we planned ERCP. We tried to cannulate from the ERCP, but the cannulation was difficult. We did pre-cut sphincterotomy, but despite that, our wire was not getting negotiated through the lesion. Patient was already inoperable case and was not going to be having any surgery done. So what next? So we did endosonography, and based on the endosonography, we found out that there is a good window in the duodenal area. So from duodenum we passed the wire, and we cannulated it through the duodenum after dilation, and we passed the stent. So this is the lesion, and this is the common bile duct. So what we have to do is we have to pass the wire from the common bile duct through the duodenal first part, and under the fluoro guidance and under the US guidance we have to do the choroidicoduodenostomy. So this is the fluoroscopy view after the passing of the wire. What first plan was, we do ERCP and put the stent. That's very simple. What is the plan B? Plan B is after the passing of the ERCP, if ERCP is not successful, do the EUS guided. This is a needle. From the needle which we pass in the CBD, and from the needle we are passing the guide wire. And what plan B is to pass the guide wire through the CBD towards the ampulla and do the rendezvous procedure. So rendezvous procedure wise, you have to again catch hold of the wire through the ampulla and do the ERCP like routine ways. where you will be unable to pass the guide wire from below. Sometimes it would be easy for the pass the guide wire from above. So this is how we are going to pass the guide wire. But when guide wire is not getting passed towards the ampulla, what is the plan C? Is to put the stent directly into the duodenum. So this is the plan C in the progress. So after the passing of the guide wire, we pass the stent over, we pass the dilator and we put the stent over it. So this is the guide wire which is being passed. And after passing the guide wire, we are going to dilate it with the Soendra dilator, and this is the guide wire inside the common bile duct. And over the guide wire we have passed the dilator. This is the dilator view from the fluoroscopy view, and this is the guide wire. So multiple dilators you have to pass, like if you want to put the 7 French stent, at least you dilate up to the 8 French dilator. So this is the dilator. And after confirming it, you have to put the stent. So this is the plastic stent which was passed through the duodenum into the common bile duct, and procedure of duodenostomy was completed. Most of the times we use a metallic stent, but when patients not that affording, sometimes we have to use the plastic stent. Plastic stent are not commonly used in duodenostomy, but multiple studies are now available where they have studied the plastic stent. We already have case series of around 8 to 10 cases where we have put the plastic stent. None of our cases got any bile leak despite putting the plastic stent. So fairly simple, fairly cost affording procedure. And we follow the patients up, and after the 5 weeks there was no jaundice or pruritus. Thank you. Any questions, please? Yes, please, Kutat bhai.
For DD gene expert in DD culture, and we have to collect the sample on loss
So
of
as you already said, Krutat bhai, we already collect the sample in 2 bottles, one for the culture and gene expert, another one for the histopathology. One more thing I want to share. Sometimes it's just based on the ultrasound or CT of abdomen. It's sometimes multiple lymph nodes been diagnosed. When we put the scope in for taking a sample from the celiac or the portal lymph node, we found that there is a mediastinal lymph node also. So what we do is we take both the samples. So if it is a lymphoma, the diagnosis, the staging differs. So they would be getting the extra advantage of CT, even if CT chest is not done, we are going to get tissue from as well mediastinal lymph node as well as the abdominal lymph node. So both the tissue which we get, and we change the treatment part if there is a both side of the diaphragm lymphoma staging differs. Thank you.
Thank you, Chintan bhai. For felicitation, I would like to call Dr. Chetan Lalseta sir on the stage. Dr. Kamani sir. Our next speaker is Dr. Awal Sadikot. He is MD DNB gold medalist and specialist in liver disease and hepatology. He has experience of more than 200 liver transplant case managements, specialist in disease of GI tract and liver of pediatric patients, and he is specialized in manometry and 24-hour pH study. His today's topic is persistent symptoms with normal endoscopy and how to proceed.
થેન્ક યુ દુષ્યંતભાઈ. ગુડ મોર્નિંગ એવરીવન. તો આપણે યુઝ્યુઅલી એવું કહીએ કે જે આંખે નરી આંખે જે દેખાય એ માનવાનું અને નરી આંખે ના દેખાય સાંભળેલી વાત ઓછી માનવાની. બટ આજે ઇન માય ટોક આઈ એમ ગોઈંગ ટુ ચેલેન્જ ધેટ સ્ટેટમેન્ટ. નરી આંખે પણ ઘણી બધી વસ્તુ નથી જોઈ શકાતી, પણ જે હોય છે અને જે આપણે શોધવાની ટ્રાય કરીએ. સો યુઝ્યુઅલી ફ્યુ યર્સ બેક, થોડા વર્ષો પહેલાં સુધી, for gastroenterologist, endoscopy was the last resort and it was the full stop. Once endoscopy was normal or once endoscopy finds something, the patient was treated according to that finding. But now the scenario has changed. Endoscopy is our first step, not the last step. Endoscopy અમારું પહેલું પગથિયું છે. એ પગથિયું ચડતા જો અમને નિદાન મળી જાય, if we are able to diagnose the patient, we treat the patient. But if we are not able to diagnose the patient after endoscopy, the treatment or the diagnosis does not stop there. અમે એના પછી ઘણા બધા પગથિયા ધરાવીએ છીએ જે અમે ચડીએ અને we try to diagnose the patient. What happens, I'll let you know. So we'll start with cases only. Case 1, 37-year-old male presented with epigastric pain and burning. He belonged to periphery and went to a peripheral doctor first. He also had complained to dysphagia to food. Now whenever dysphagia is there, another important part to ask is whether it is only to solid food or to both solid and liquid food. That will give us some clue in your day-to-day OPD whether this patient is having what kind of dysphagia. Only to solid means some mechanical dysphagia is there. Solid plus liquid, you have to think of something else than mechanical. ખાલી esophagus નું narrowing નથી, ખાલી stricture નથી, કંઈક બીજું થઈ રહ્યું છે. But as he went to periphery to some clinician and his main complaint was epigastric pain and burning, and then it was dysphagia. There was no nausea, vomiting, chest pain, weight loss, anything. No comorbidities or no significant past history. So that doctor in the periphery, he advised endoscopy. He underwent endoscopy there, and the endoscopy report was something like this. So esophagus was normal, there was some gastritis, and ultimately patient was having some epigastric pain as well. So he was given PPI, proton pump inhibitor, as a part of treatment of gastritis. And patient improved also. Patient's epigastric pain and burning disappeared. હવે પેશન્ટને દુખાવો અને બળતરા ગઈ એટલે એકચ્યુઅલી એનું ધ્યાન ગયું કે હવે આ જે ડિસ્ફેજિયા હતું, જે ખોરાક ઉતારવામાં તકલીફ હતી, એનાથી તકલીફ વધારે છે, because he got rid of those symptoms. So he again went back to the same person, the same doctor, કે સાહેબ હવે મને દુખાવો બળતરા તો નથી, but I am still, મને ઉતારવામાં તકલીફ પડે છે. The doctor advised કે ભાઈ તારી એન્ડોસ્કોપી નોર્મલ છે, તને કંઈ છે નહીં, તને આ ટેન્શનથી થાય છે. This is the normal scenario. When we don't see anything, we attribute everything to something which we cannot see, psychiatric condition or tension or stress or anxiety. So patient was started on anxiolytic agents, but he did not improve. So what happened after that? That will unfold after few minutes. So this is one case, dysphagia with fairly normal endoscopy, no response to treatment, no response to anxiolytic agents. Our case 2 is young female. She used to complain of persistent heartburn. છાતીમાં બેડા કરે, બળતરા થયા કરે, continuous, દિવસ રાત ઊંઘ ઉડી જાય, શું કરવું? But there was no complaint of nausea, vomiting, volume reflux. Volume reflux એટલે જે કોગળા જેવું બહાર આવી જવું, જમીને ખોરાક બહાર આવે કે ઘણાને એસિડનો કોગળો બહાર આવે. So there was no volume reflux and there was no dysphagia. Her upper endoscopy was done, which was suggestive of small hiatus hernia, and associated with it was some gastritis. So again she was started on proton pump inhibitors and lifestyle modifications, જે આપણે hiatus hernia કે reflux વાળા પેશન્ટમાં કહેતા હોઈએ. યુઝ્યુઅલ જે ડાયટરી ઇન્સ્ટ્રક્શન્સ આપતા હોય એ બધા ઇન્સ્ટ્રક્શન આપ્યા. તો એને થોડું ઘણું પાર્શિયલ ઇમ્પ્રુવમેન્ટ થયું, થોડી ઘણી બળતરાની જે ફ્રીક્વન્સી હતી એ ઓછી થઈ, બટ સ્ટીલ she was not satisfied. She said, no, I am still not happy with my life. The symptoms are persistent. Do something but cure me completely. So because hiatus hernia was there, she was advised fundoplication. Whether she underwent it or not, that we'll see after a few minutes. So this is our third case, a middle-aged female. She complained of dysphagia to both solid and liquid, and she was referred just for endoscopy in view of dysphagia. This was her endoscopic finding. There was some candidial esophagitis, and associated with that some hiatus hernia. Rest of the things were normal. Sometimes candidial infection in esophagus may also lead to symptoms like dysphagia or odynophagia. Patient ne એવું લાગે ઘણીવાર કે કંઈક અટકે છે. And if we treat candida, patient improves. So in view of the presence of candidial infection, she was given antifungal agents, but there was no improvement in her symptoms. So after that, she was referred to us. Our fourth case today is an elderly male who had persistent constipation. He was elderly, but there was no history of diabetes. Her thyroid profile, which is a baseline thing to rule out in a constipated patient, was done. It was normal. He was started on laxatives, but there was poor response. એને ક્યાંકથી જે routinely આપણે prescribe કરતા હોય ક્રીમાફિન કે મિલ્ક ઓફ મેગ્નેશિયા કે ટાઈપની એને laxative મળેલી, but there was poor response. So colonoscopy was done. Colonoscopy again showed just melanosis coli, which is sign of chronic abuse of some Ayurvedic medicines, etc. પણ એ સિવાય ક્યાંય મિકેનિકલ ઓબ્સ્ટ્રક્શન નહોતું કે કોઈ સ્ટ્રક્ચરલ એબનોર્માલિટી વોઝ એબસન્ટ ઇન કોલોનોસ્કોપી રિપોર્ટ. So we went one step further ahead and we did colonic transit study in this patient. Now in colonic transit study, as you can see, જે નાના નાના metallic beads છે. Patient is advised to swallow these metallic beads at a special regular interval એનું આખું protocol હોય which we give to the patient. And then after giving these beads, આપણે 12 and 36 hours પછી એનો X-ray કરતા હોઈએ છીએ. If after 36 hours of X-ray also, if you can see less than 5 metallic beads inside the colon, બાકી બધા સ્ટૂલમાં નીકળી ગયા હોય, તો that is a normal report. But if we can see more than 5 metallic beads in the large bowel, then it means patient is having some motility problem with the large bowel. Now if it is diffused throughout the large bowel, as you can see in this case, કે તમને આખા large bowel માં નાના નાના metallic beads દેખાય છે. So it is suggestive of slow transit constipation. It means કે large bowel ની જે normal speed હોવી જોઈએ, normal motility હોવી જોઈએ, એ થોડી slow થઈ ગઈ છે, અને because of that patient is not able to pass normal stool. So these cases, these are the ones who respond better to prucalopride. એટલે already he had poor response to milk of magnesia and other bulk laxatives, so he was started on prucalopride plus polyethylene glycol, but still the response was suboptimal. Though patient's stool output was better, પણ હજી જે પેશન્ટ કહે ને કે સાહેબ મજા આવી ગઈ, એમ મજા નહોતી આવતી. હજી એવું લાગતું હતું કે કંઈક હજી બચી જાય છે, જેના માટે પેશન્ટને રિપીટેડલી સ્ટૂલ પાસ કરવા જવું પડતું હતું. હી હેઝ ટુ સ્ટ્રેઇન અ લોટ, પણ હજી પેટ આખું ખાલી થાય એવું એને ફિલિંગ આવતી નહોતી. So these are the 4 cases where endoscopy or colonoscopy were done. Endoscopy, colonoscopy ma hardly there was anything positive. Even if something was positive and it was treated, patient did not improve. So what else? Does it mark the end of road for patient as well as clinician? કે ભાઈ હવે આમાં નથી મળતું, આનાથી વધારે શું કરી શકાય? થોડા વર્ષો પહેલા સુધી એવું જ હતું, but in present scenario in Rajkot, no, it is not like that. So what we do? We'll see how to proceed. So we'll have a brief idea about manometry. Okay, volume. Okay, otherwise I'll speak. Time bagad. Okay, so manometry is basically what? Manometry is to measure the pressure. આપણે એન્ડોસ્કોપીમાં શું જોઈ શકીએ? એન્ડોસ્કોપીમાં we can only see the wall of the esophagus or large bowel or stomach, કે અંદરનું જે mucosal lining છે એ દેખાય, ક્યાંય narrowing છે, stricture છે તો એ દેખાય, ક્યાંય ટ્યુમર છે એ દેખાય. But actual esophagus નું કામ શું છે? Whenever we are swallowing, the esophagus is propelling the food downwards, અને એ esophagus ની peristalsis થી થાય. એ કેટલું પ્રેશર જનરેટ કરે છે એનાથી થાય. અને once the food reaches the lower esophageal sphincter, ત્યારે એ સ્ફિંક્ટર રિલેક્સ થઈને ફૂડને ઇસોફેગસમાંથી સ્ટમકમાં જવા દે છે કે નહીં, એ પ્રક્રિયાથી થાય. This whole process cannot be seen through endoscopy, but if there is some problem with esophageal motility, એમાં બરાબર પ્રેશર ના હોય, એની પેરિસ્ટાલ્સિસ બરાબર ના હોય, લોઅર esophageal sphincter રિલેક્સ ના થતું હોય, તો પેશન્ટને ડિસ્ફેજિયા થઈ શકે, which cannot be seen by endoscopy, which can be seen through manometry. So this is the actual video recording when we are performing the manometry. So we pass that manometric catheter through the patient's nose. આપણે જેમ રાઇસ ટ્યુબ મૂકતા હોય એવી જ રીતે ઉતારીએ. And on this screen we can confirm કે એનો જે lower end છે એ lower esophageal sphincter ને પાસ થયો છે કે નહીં. And once the catheter's lower end is across the lower esophageal sphincter, પછી અમે પેશન્ટને વેટ સ્વેલો એટલે કે 5 ml વોટર આપીએ. એન્ડ વિથ ઇચ સ્વોલો વી સી કે આ અપર ઇસોફેજિયલ સ્ફિંક્ટરમાં શું થાય છે, ઇસોફેગસમાં શું થાય છે અને લોઅર ઇસોફેજિયલ સ્ફિંક્ટરમાં શું થાય છે. ઇટ વિલ ગીવ અસ એક્ઝેક્ટ પ્રેશર અને એક્ઝેક્ટ રિયલ ટાઈમ મોટિલિટી ઓર પેરિસ્ટાલ્સિસ ઓફ ઇસોફેગસ એન્ડ રિયલ ટાઈમ રિલેક્સેશન ઓફ લોઅર ઇસોફેજિયલ સ્ફિંક્ટર. એટલે આપણે પેશન્ટની ઇસોફેગસની અંદર બેઠીને એને પીવડાવીને જોઈએ છીએ કે અંદર શું થઈ રહ્યું છે. ઇટ ઇઝ and it gives the exact idea કે where is the problem, what is the problem. So as the patient swallows, that upper top green line is upper esophageal sphincter, એ રિલેક્સ થાય અને એમાંથી પાણી નીચે આવે એટલે ગ્રીન વેવ અને નીચે જે રેડ વેવ દેખાય છે that is esophageal peristalsis, અને સૌથી નીચે જે આડો બાર દેખાય છે again green and red, that is lower esophageal sphincter. So this is the manometry machine, and as you can see, this is upper esophageal sphincter, this is esophageal peristalsis, and this is lower esophageal sphincter. Now how do we get the idea about pressure? It is color coded. So blue you can see is the lowest pressure. સૌથી ઓછું પ્રેશર હોય ત્યાં બ્લુ કલર હોય. જેમ જેમ પ્રેશર વધે તમને સાઈડમાં એક ઊભી લાઈન દેખાય છે. લોએસ્ટ વન બ્લુ છે, સૌથી ઉપર રેડ છે, ડાર્ક રેડ. જેમ જેમ પ્રેશર વધે this line, આ સૌથી લો પ્રેશર છે, આ સૌથી ઉપર જાય એમ હાઈ પ્રેશર આવતું જાય. જેમ પ્રેશર વધે એમ કલર ચેન્જ થતો જાય. સો એટ રેસ્ટ અપર એસોફેજિયલ સ્ફિંક્ટર ઇઝ ક્લોઝડ, એટલે આ નોર્મલ પ્રેશર સાવ ઓછું બ્લુ છે, અહીંયા ગ્રીન પ્રેશર છે, એટલે અહીંયા બંધ થયેલો છે વાલ્વ. નાઉ ધીસ ઇઝ ધ ટાઈમ વેન વી ગીવ ધ સ્વોલો. જ્યારે પેશન્ટ પાણી પીવે ત્યારે અપર સ્ફિંક્ટર પહેલાં રિલેક્સ થાય, પહેલાં ગળાની નીચે ઉતરે. રિલેક્સ થયું એટલે આ કલર ગ્રીનમાંથી બ્લુ થયો. સી હાઉ બ્યુટિફુલી ઇટ ઇઝ સીન. એટલે પાણી નીચે ઉતર્યું, જેવું પાણી નીચે ઉતર્યું સ્ફિંક્ટર પાછું બંધ થઈ ગયું અને ઇટ રિમેન્સ ક્લોઝડ. નાવ વન્સ ઇટ રીચીસ ધ ઇસોફેગસ, ઇસોફેગસની વોલ શું કરે, પાણીને નીચે પુશ કરે, નીચે ધક્કો મારે, એમાં પેરિસ્ટાલ્સિસ આવે. સો એઝ ધ વોટર ગોઝ ડાઉન, ધીસ યુ કેન સી, પહેલાં બ્લુ હતી ઇસોફેગસમાં પેરિસ્ટાલ્સિસ એટલે કે પ્રેશર સાવ લો હતું, ઇટ ઇન્ક્રીઝિસ ટુ ગ્રીન. પછી વધારે નીચે થયું એટલે ત્યાં ગ્રીન થયું, વધારે નીચે થયું ત્યાં ગ્રીન થયું, અને એમ કરતાં પ્રેશર પેરિસ્ટાલ્સિસ અહીંયા પહોંચ્યું. This is lower esophageal sphincter. You can see at rest it was closed, green હતું, બંધ હતું. As the water reaches downwards, it becomes blue. Pressure ઘટી ગયું, sphincter ખુલી ગયું, water goes inside, again it becomes closed, એનું pressure વધી ગયું. How beautifully we can see કે પેશન્ટનું પાણી ક્યાં પહોંચ્યું છે અને ક્યાં અટક્યું છે. આમાં ક્યાંય પણ પાણી અટક્યું હોય તો that gives us idea કે ત્યાં high pressure zone થઈ જાય. ઘણી વખત લોઅર ઇસોફેજિયલ સ્ફિંક્ટર ખુલે જ નહીં, ગ્રીનનું ગ્રીન, અથવા ઘણી વખત બહુ હાઈ પ્રેશર હોય તો રેડ થઈ જાય. અને વી આર એબલ ટુ સી કે આ ક્યાં લેવલે પ્રોબ્લેમ કરે છે, વિચ વી કેન નેવર સી ઓન એન્ડોસ્કોપી. સો વોટ આર ધ ઇન્ડિકેશન્સ? ઓફકોર્સ ધ મોસ્ટ કોમન ઇન્ડિકેશન ઇઝ ડિસ્ફેજિયા, especially when endoscopy is normal. Again, you have to pay attention to the symptom dysphagia to solid plus liquid. Always think of motility disorder. Then non-cardiac chest pain. આવા ઘણા પેશન્ટો એન્જિયોગ્રાફી આતે બધું થઈ જાય, but still there is midline chest pain which just fails to go off. આવા પેશન્ટને ઘણી વખત distal esophageal spasm કે nutcracker esophagus નામની motility disorder esophagus ની હોઈ શકે, which we can diagnose with manometry. ઓડાઇનોફેજિયા, પેઇનફુલ સ્વેલોઈંગ, જ્યારે ખોરાક ઉતારે ત્યારે ખૂબ દુખે, પેશન્ટને એમ લાગે કે એટેક આવી જશે એટલો દુખાવો થાય છે. અગેન ઇસોફેજિયલ મોટિલિટી ડિસઓર્ડર હોઈ શકે, વી કેન ડાયગ્નોઝ વિથ ધ હેલ્પ ઓફ મેનોમેટ્રી. persistent heartburn and regurgitation, ઘણી વખત પેશન્ટ વિથ એકેલેઝિયા કાર્ડિયા અને સિમ્ટમ્સ રિફ્લક્સ જેવા લાગતા હોય, પણ એકચ્યુઅલી ઇટ ઇઝ નોટ રિફ્લક્સ, ઇટ ઇઝ ધ regurgitation of the food from the esophagus itself. અને એમાં આપણે મેનોમેટ્રી કરીને જોઈ શકીએ કે this is not GERD, this is echinacea cardia. Anorectal manometry, of course, the most common indication is chronic constipation, where other systemic causes and structural causes have been ruled out. Diabetic નથી, thyroid નથી, colonoscopy normal છે, slow transit નથી અથવા slow transit છે પણ ટ્રીટમેન્ટનો રિસ્પોન્સ નથી, then anorectal manometry plays a role. Fecal incontinence, ઘણીવાર after delivery, after some gynecological surgery, after injury to perineal region, પેશન્ટને fecal incontinence થાય, which can be diagnosed and demonstrated beautifully with the help of anorectal manometry. Patients with solitary rectal ulcer syndrome, કે જેને કોઈ રીઝન વગર રેક્ટમમાં અલ્સર થતું હોય, those can have dyssynergic defecation અને એને ડાયગ્નોઝ થઈ શકે મેનોમેટ્રીથી. Hirschsprung disease, again anorectal manometry can be diagnostic. And biofeedback training is treatment part actually. So once we have diagnosed constipation or fecal incontinence, then treatment is not pharmacological. દવા આપીએ ક્યારેય આ દર્દી પૂરેપૂરા સાજા ના થાય. Treatment is through a specialized therapy known as biofeedback, which again can be given with the help of manometry and which helps the patient in getting rid of the symptoms. This is 24-hour peer study machine. This is the catheter and this is the machine. Actually આ હોલ્ટર જેવું જ હોય. આ કેથેટરને અમે અગેન આર્ટની જેમ નોઝમાંથી પાસ કરીએ, ઇસોફેગસમાં રાખીએ. The lower end of the catheter tip એ એલિયસની 5 સેન્ટીમીટર અપો ફિક્સ કરી દઈએ અને એનો બહારનો જે એન્ડ છે એ મશીન સાથે ફિક્સ થયેલો હોય. પેશન્ટ મશીનને પર્સની જેમ પહેરી રાખે. This remains inside for 24 hours. This measures the acid exposure in the lower esophagus. જે રિફ્લક્સવાળા પેશન્ટ હોય, હાર્ટબર્ન, બળતરા થાય, તો એમાં બળતરા એકચ્યુઅલ એસિડ રિફ્લક્સને લીધે છે કે નહીં, whether that is organic or functional, can be perfectly differentiated with the help of this machine. Indication of 24-hour peer study is before anti-reflux surgery. hiatus hernia છે, ફંડોપ્લાઇકેશન કહી દીધું, પણ what if કે પેશન્ટને રિફ્લક્સ છે જ નહીં, હાર્ટબર્ન ઇઝ જસ્ટ ફંક્શનલ હાર્ટબર્ન, પેશન્ટની સર્જરી થઈ જશે, પેશન્ટને ફાયદો નહીં થાય. But this test will tell you whether the patient will be benefited with the help of surgery or not. After anti-reflux surgery, પેશન્ટની સર્જરી થઈ ગઈ પણ પેશન્ટ હજી કહે છે કે સાહેબ હજી અમને બળતરા તો થાય જ છે, તમારી સર્જરીથી ફાયદો થયો નથી. તો we can demonstrate કે before surgery, see this was your acid score, after surgery this is your acid score, there is significant improvement in acid score. Now whatever your symptoms are there that are not because of acid reflux, પણ હવે અહીંયા નથી, હવે ખરેખર અહીંયા છે, that we can prove. Persistent patients with reflux symptoms resistant to treatment. PPI આપી દીધી, જે હતું બધું કરી લીધું પણ ફાયદો નથી થતો. એમાં we can see કે whether there is actual acid reflux, દવાનો ડોઝ વધારવાની જરૂર છે કે નહીં, કે આને એસિડ બ્રેક થ્રુ ઇન સ્પાઇટ ઓફ મેડિસિન થાય છે, દવાનો ડોઝ વધારવો જોઈએ, શું કરવું જોઈએ. અને પેશન્ટ વિથ એક્સ્ટ્રા એસોફેજિયલ સિમ્ટમ્સ લાઇક ક્રોનિક કફ, ક્રોનિક અસ્થમા, recurrent laryngitis, recurrent caries in posterior molars, આ બધા એસિડ રિફ્લક્સના મેનિફેસ્ટેશન હોઈ શકે. કે ઘણી વખત અમારી પાસેથી ચેસ્ટ ફિઝિશિયન માટે આવતા હોય કે 2-3 વર્ષથી કફ છે, વી હેવ ટ્રાઇડ એવરીથિંગ, પેશન્ટ ઇઝ નોટ રિસ્પોન્ડિંગ, વી ગો ફોર 24-hour peer study, it shows કે this is reflux induced cough. એનો રિફ્લક્સ ટ્રીટ કરો અને કફ ગાયબ થઈ જશે. Same happens with sometimes asthma. So now coming back to our clinical case scenario, first case was a young male with dysphagia with normal esophagus and no response to symptomatic treatment. We did the manometry. If you can see, once we give the wet swallow, અહીંયા upper esophageal sphincter relax થાય છે, પણ પછી આખી ઇસોફેગસમાં એક સાથે પેરિસ્ટાલ્સિસ આવે છે, આમ ઊભી લાઈન છે. જો તમને પેલું નોર્મલ યાદ હોય તો એમાં આવી રીતે આવતું હતું, સ્લાન્ટ આવતું હતું. આ પેશન્ટમાં શું હતું, ઊભી લાઈન હતી. એનો અર્થ શું કે ધ મોમેન્ટ વોટર એન્ટર્સ ધ ફૂડ પાઇપ, આખી ઇસોફેગસ એક સાથે કોન્ટ્રાક્ટ થાય છે, ઇટ મીન્સ કે વોટર ત્યાં ટ્રેપ થાય છે, વોટર નીચે જતું નથી. નંબર 1. નંબર 2, જેમ તેમ કરીને વોટર નીચે પહોંચે છે તો ધીસ લોઅર ઇસોફેજિયલ સ્ફિંક્ટરનું પ્રેશર ઘટતું જ નથી. ઇટ રિમેન્સ હાઈ ને હાઈ. ગ્રીનનું ગ્રીન જ રહે છે, બ્લુ નથી થતું. ઇટ મીન્સ even if the water reaches down, the lower esophageal sphincter is not allowing the water to pass from esophagus to the stomach. So this was the, and then we confirmed it with timed barium. So this was the patient of achalasia cardia. It was a very short history, 1-2 મહિના જ થયા હતા, એટલે there were no endoscopic changes to pick it up from esophagus, એટલે esophagus normal હતી. But we went ahead with poem and patient had marked improvement. Case 2 was young female with hiatus hernia, persistent heartburn, but only partial response to treatment, and she was advised fundoplication for complete relief. Now she came to us for second opinion. What we did? We did manometry first. Manometry showed there was some hiatus hernia. If you can see here, there are 2 pressure lines. એક આ લાઇન છે અને એક આ ફેઇન્ટ લાઇન અહીંયા દેખાય છે. એટલે આ જે લાઇન છે ને, ધીસ ઇઝ બીકોઝ ઓફ ડાયાફ્રામ. આ ડાયાફ્રાગમેટિક પ્રેશર છે અને ધીસ ઇઝ લોઅર ઇસોફેજિયલ સ્ફિંક્ટર, જે એકદમ ફેઇન્ટ લાઇન છે. એટલે ધેર ઇઝ અ ગેપ ઇન બિટવીન. એટલે હાઇટસ હર્નિયા તો છે, એમાં કોઈ ડાઉટ નથી. એન્ડ વી ડીડ ધ સ્વોલો સ્ટડી વિચ ઇઝ ફેરલી ઓકે. પેશન્ટનું સ્વોલો ઓકે છે, એટલે મોટિલિટીમાં કંઈ પ્રોબ્લેમ નથી. અને એન્ડોસ્કોપીમાં જે હાઇટસ હર્નિયા દેખાણું એ આપણે કન્ફર્મ કર્યું મેનોમેટ્રીથી. સો ડાયગ્નોસિસ ઇઝ કન્ફર્મ. નાઉ વી હેવ ટુ ડિસાઇડ what is the reason for heartburn. So we did 24-hour pH study. This is the graph of 24-hour pH study. This cutoff is important. જે આ 4ની cutoff છે એ important છે. This is pH cutoff. એટલે 4ની નીચે કેટલા એપિસોડ છે, pH less than 4 વાળા કેટલા રિફ્લક્સ છે, that is only important for any patient with GERD. 24-hour graph પછી the scoring system comes, and if you can see, everything was within normal limit. Total reflex time was 3% of 24 hours. Total reflux time upright was 4.6%, supine was 0.3%. Reflux episodes less than 70, more than 5-minute reflux were nil. Longest reflux was only 2.6 minute. બધા જ પેરામીટર નોર્મલ છે. પ્લસ ધીસ ડીમિસ્ટર સ્કોર ઇઝ ધ ઓબ્જેક્ટિવ એવિડન્સ કે ખરેખર એસિડ ઉપર આવે છે કે નહીં. આ સિમ્ટમ ઉપરથી છે કે પેશન્ટને સિમ્ટમ કેટલી વાર થયા. ધીસ મેઝર્સ કે 24 કલાકમાં કેટલી વખત એસિડ ઉપર આવ્યું એનો સ્કોર છે. ઇફ ઇટ ઇઝ મોર દેન 14, you can say કે આ પેશન્ટને સિગ્નિફિકન્ટ એસિડ રિફ્લક્સ થાય છે. It was less than 14. So even objective wise or subjectively, this patient did not have reflux disease. જો આ પેશન્ટની સર્જરી થઈ હોત તો પેશન્ટના સિમ્ટમ રિલીવ ના થયા હોત. Because even though hiatus hernia was there was no significant acid reflux. The heartburn was not because of acid reflux. તો એ રિફ્લક્સ બંધ કરવાથી કંઈ ફાયદો જ નથી અને રિફ્લક્સ જ નથી. This was purely a case of functional heartburn. We started her on amitriptyline and she improved. And major surgery was prevented. Moreover, a surgeon's litigation was prevented. Otherwise, after surgery, it was bound to happen. Case 3, middle-aged female with dysphagia with esophageal candidiasis, but without any response to antifungal treatment. She was referred for manometry. Manometry, if you can see, this is upper esophageal sphincter. The moment we give wet swallow, it relaxes. There is some movement in the upper part of esophagus, but after that, there is no peristalsis. There is no peristalsis. And because the water does not reach the lower esophageal sphincter because of lack of peristalsis, it does not relax. નીચે પહોંચતું જ નથી તો આ ખુલે ક્યાંથી? So this patient was not having any esophageal motility. It was absent contractility in esophagus. And આવા પેશન્ટમાં then we took the further history because she was just referred for manometry. We first did the test. The test was suggestive of something. So we dig deeper. And when we dug deep, we found that patient was also having some joint pain and some thickening of, tightening of skin in the fingers and around in perioral cavity. So we thought that it might be the case of scleroderma. She was referred to rheumatologist and it indeed turned out to be scleroderma. Last case, elderly male with chronic constipation with normal colonoscopy. Transit study was suggestive of slow transit constipation, but there was partial response to precalopride. Because there was partial response to precalopride, in spite of slow transit constipation, we subjected him to anorectal manometry. Anorectal manometry, this is the area of anal sphincter and this is the area of rectum. Again, the darker the color, the more the pressure. This is at rest. જ્યારે પેશન્ટ જોર નથી કરતો, સ્ફિંક્ટર રિલેક્સ રાખે છે, ત્યારે પણ યુ કેન સી ધ સ્ફિંક્ટર ઇઝ persistently in high pressure zone. પેશન્ટનું સ્ફિંક્ટર રિલેક્સ થતું જ નથી, બંધનું બંધ જ રહે છે. એન્ડ વેન પેશન્ટ ઇઝ આસ્ક ટુ બેર ડાઉન, જ્યારે પેશન્ટને આપણે કહીએ કે સ્ટૂલ પાસ કરતા હોય તો તમે પાસ કરો સ્ટૂલ, યુ કેન સી દેર ઇઝ સમ રાઇઝ ઇન રેક્ટલ પ્રેશર, પણ જે એનાલ સ્ફિંક્ટર છે એનું પ્રેશર ઘટવું જોઈએ તો જ ઉપરથી સ્ટૂલ નીચે આવે, કે રેક્ટલ પ્રેશર વધ્યું, એનાલ સ્ફિંક્ટર ખુલ્યું તો સ્ટૂલ પાસ થયું. So there is increase in rectal pressure associated with there is paratoxical increase in anal sphincter pressure. Anal sphincter એ બંધ થઈ જાય છે. અહીંયાથી ધક્કો મારીએ બહાર નીકળે ને દરવાજો લોક કરી દીધો, બહાર કેવી રીતે નીકળે? So this was a case of type 1 dysynergic defecation. We subjected this patient to biofeedback. Biofeedbackમાં શું કરીએ, પેશન્ટને આ બતાવીએ એકચ્યુઅલી કે જો ભાઈ તમે અહીંયા જોર કરો છો તો અહીંયા જોર તો બરાબર થાય છે પણ અહીંયા ખુલતું નથી. અમે એને રિપીટેડલી એક્સરસાઇઝ કરાવીને ટ્રાય કરીએ કે યુ ટ્રાય ટુ ઇન્ક્રીઝ ધીસ પ્રેશર એન્ડ યુ ટ્રાય ટુ રિડ્યુસ ધીસ પ્રેશર. એક વખત પેશન્ટના મગજમાં એ જોર બેસી જાય કે મારા માટે સાચું જોર શું છે, તો બાકી બધા જોરમાંથી એને મુક્તિ મળી જાય. So he was subjected to biofeedback and there was significant improvement in response to prucalopride and PEG. So as we discussed, this is the biofeedback. It is used to correct dyssynergia and also to enhance the rectal sensory perception. Even in patient with fecal incontinence, આપણે anal sphincter ની exercise કરાવી શકીએ અને એનો ટોન વધારી શકીએ. So conclusion, normal endoscopy doesn't mean non-organic diagnosis always. High index of suspicion to diagnose is always required. Manometry is an evolving science, but can be a boon or an add-on to a normal endoscopy. ઘણા બધા પેશન્ટને સાયકિયાટ્રી ટ્રીટમેન્ટ ચાલુ થવામાંથી આપણે બચાવી શકીએ. 24-hour peer study can change the management, can prevent the surgery as well. Biofeedback, when successful, can give medicine-free relief or can be synergistic to the existing medical management. Thank you very much.
Any question?
The manometric catheter? Manometric catheter single can be used. Since 4 or 5 years we have been doing this. We have not yet changed manometric. No. Yes, but it's a very fragile thing. We have to take care of the machine like a newborn child. But if we take proper care, the longevity is good.
I must say that this type of investigative modalities are very, very important because what we see in endoscopies or in imaging is something which is there. But what we see in manometry is something which is not seen there. So many of the times our diagnosis also changes and our treatment protocols also changes. When I started my practice, I used to do a lot of fundoplications because they used to come with refluxes and all. I'll honestly admit it because of the symptoms and all. But sometimes we feel that we not get a good feedback after surgery. So in fact, my practice has also changed a bit. A lot of that number of fundoplications, anti-reflux surgeries I do is not as frequent as what I used to do before. Because I also realized that something more to it, the functional one, the motility one, which sometimes we miss, before we embark on a surgical practice. So that is very well.
Some children may have stool incontinence. Do you advise rectal manometry in this case?
Not straight away. See, again, most of the children with fecal incontinence, as sir said, if we do X-ray, the colon is loaded with feces, and most common reason again of incontinence is overflow incontinence. There was so much stool inside, the patient is not evacuating it properly, maybe because of constipation, maybe because of painful passage of stool. The child is holding back the stool, and whatever little he is passing is because of overflow only. So most commonly it is not required. When we think of Hirschsprung, when we suspect Hirschsprung in these patients, then we advise manometry.
Procalopride and PEG both at a time, or
Can be given because they have separate different mechanisms actually. So can be used, and they have synergistic effects.
Well, excellent cover.
Thank you, sir.
More difficult, more complicated cases, and very difficult to interpret this and make it very easy to understand. Thank you.
Thank you, sir. Thank you very much.
Take my towel. For felicitation, I would
liberally. So something which
In most of the cases, what you are talking about are IBS, irritable
irritable
bowel
bowel
syndrome.
syndrome.
So nothing works basically except physiotherapy and psychotherapy, cognitive
But
therapy.
they are empirically used for
Yes,
constipation.
but there is no harm in using them. There is nothing you can offer them otherwise.
And IBS patients are always in search of a newer molecule. You give something new for 6 months, they are happy.
ના પણ વન ઇન્ડિકેશન પેશન્ટ કોન્સ્ટિપેશન આવે તો પહેલા પૂછવાનું કે તમારે શું પ્રોબ્લેમ છે કબજિયાત છે આપણે પૂછીએ કેટલા દિવસે જાઓ છો એટલે અઠવાડિયે 2 વખત જાઓ છો ધીસ ઇઝ ધ વન ઓફ ધ મોસ્ટ ઇન્ડિકેશન ટુ પ્રોબ્લેમ if you start then on follow up they says nowadays I am going alternate day then you further you can continue up 9 months then they say I am passing daily 1 stool per day this is the most common indication second in elderly patient beyond 70 very careful start with 1 milligram and watch for toxicity. It doesn't produce any major side effect, but we have to be careful. We are using it pediatric also, 1 milligram per day, with excellent results of prochlorperoxide.
One more history point which I use to differentiate between slow transit and this dysynergic infection and constipation patients. Prochlorperoxide earlier, patient may say, sir, now stool is loose, but still I am not satisfied, I am not able to evaluate it completely. Then you have to think I am dyspnea dysynergy which I showed in the manometry. So this is one tool I use in my pathology. I subject these patients to manometry.
For felicitation, I would like to call Dr. Karthik Sushariya and Dr. Sanjay Gilal, sir. Please come on stage.
જેલેન્સ્કી જેવું લાગે છે ઉક્રેનનો
Next lecture is by Dr. Amit Acharya, sir. He is a senior consultant gastrosurgeon, renowned and experienced gastrosurgeon of Southwest and West region, specialized in all types of advanced laparoscopy, gastrosurgeries, as well as hepatobiliary and GI onco surgeries. His today's topic is minimal access approach for complex GI surgeries. So I call upon Dr. Amit Acharya, sir, to deliver his talk.
Good morning and thank you, Dushan, for the introduction. And it's very difficult after Dr. Raval's presentation because it's very difficult for me to catch hold of all the audience after you. So my topic is minimal access approach for the complex GI surgery. As I said, it's very difficult for me for a pre-lunch session. Any lectures before just pre-lunch, all the audience are very much tired of it. So I'll just try to make it more attractive. So I made it not a lecture, I just made it a video presentation rather. All type of these complex surgeries need a team. So we have a team including intensivist and a base team of a gastroenterologist. So this was my patient. I am not that much lucky. This is just to draw your attention on the screen. So the first case is a 52-year female patient with history of organ of abdominal pain since 4 years, and she's hypertensive and diabetic. On evaluation, mucinous cystic neoplasm of the pancreas was diagnosed, and the plan was left distal pancreatectomy with splenectomy. It was a huge one. All the vaccines were given 14 days prior to the surgery. આ લાઇટ્સ બંધ કરી દો ને આગળની પ્લીઝ. So this was a CT scan. I'll just so this was the અહીંયા નથી આવતું, આમાં આવે છે. It is running here. અહીંયા જો ને. અહીંયા તો ચાલુ છે. something wrong. એમની આમાં રન થરે છે, આમાં રન નથી થતો, આમાં નથી આવતો. અલગ છે વિડીયો. નહીં હવે કરો. હા ફોલ્ડરમાં પ્લે કરી દો, છોડો ને. નહીં I'll just try it last time. આ હાઇપરલિંક કરીએ ને એટલે આ પ્રોબ્લેમ થાય છે, એવું છે. સોરી. નહીં પણ આ ના નથી આમાં. ડાયરેક્ટ વિડીયો પ્લે કરું છું, ફોલ્ડરમાં છે તોય નથી આવતું. આમાં જે આવે છે એમાં નથી આવતું. શેમાં? હા પણ આમાં આવવું જોઈએ ને. નહીં નહીં આ નહીં નહીં આ હા હા નહીં પણ આનું ટ્રાન્સમિશન ત્યાં થતું જ નથી. હા ના થઈ ગયું, ચાલો તો હવે થઈ જશે. નહીં પીપીટી થઈ જશે હવે. હવે થઈ જશે. હા ના થઈ ગયું, વાંધો નહીં, હવે આવી જશે. કારણ કે બધાના લોચા થઈ ગયા. આમાંથી કરો. હા
એમનેમ કોમ્પ્યુટરમાં પ્લે થાય.
હા બસ એ જ કરું છું.
એમનેમ ડાયરેક્ટ કોમ્પ્યુટરમાં ડેસ્કટોપ ઉપરથી પ્લે કરો.
ડન. ઓકે. So this was the CT scan report, and I'll just show you again. You can see a large mucinous cystic adenoma, mucinous cystic neoplasm of the pancreas. It was approximately 10 by 11 centimeter in size, and EUS was done, and you can see a nice large cyst. This is a string sign being demonstrated by Dr. Rawal sir. This is a classical for a mucinous cystic neoplasm. So we planned for a laparoscopic distal pancreatectomy with splenectomy. The first thing was to open up the lesser sac. I use harmonic in the form of sonicism. Patient was little bit of overweight. We thought of just start with the laparoscopy, and if possible, because the tumor size was very much big, so if possible, if it is not progressing, then we'll convert it to open. But slowly and progressively we could able to dissect it. See, once laser sac is open, you can nicely clearly see the tumor which was arising from entire body and the tail region. So entire body and tail region was completely replaced by the cystic tumor. I always ask my anesthetist to keep a little bit of hypotensive anesthesia. After that, the lower border of the pancreas is being dissected off. Now you can see a normal pancreas over there. This is the normal pancreas. Slowly and gently you just dissect it down. Now this is the area of head and neck region. These are all flimsy adhesions. This is being taken care of. Now the structure which is seen is just above the pancreas. This is the so just before the tunnel, you make sure that the above dissection is proper. Now again we came below, and structure which is bluish in color, this is a portal vein. So this is a tunnel which is also known as tunnel of love. That's why it is very risky. So this is the tunnel between a portal vein and above is the pancreas. You have to be very gentle. Slowly we just dissect it and we reach up to the upper edge. Here also we have to be very gentle not to poke any other vital structure. So you can see the tip of the Maryland above. Once the tunnel is made, now this is the umbilical tape. We encircle it and loop it just to have a good exposure of tunnel. Now we can clearly see the entire portal vein. Here is the splenic vein which is joining here. It's clearly visible. Now the difficult part was the dissection of the splenic artery, which was actually very much densely adherent to the cystic lesion. The difficulty level was here is just because if we dissect too much pointing down the Maryland down, there are chances of injuring the cystic lesion. So slowly and gently we just encircle the cystic artery. A mucinous cystic adenoma is a pre-malignant condition, so we should avoid contamination. So this is the cystic artery being dissected off. A gentle and meticulous dissection is very important. We have to keep very calm and dissect it. And this is being looped by the vascular loop. Now to clip it, we need a good space. So again with the hook, with a very minimal cautery setting, you just dissect it off. Now you can see it's nicely being hooked. The idea of cautery is look, hook and then cook. So after that, these are the hemolock clip. This is bit bigger in size, but we just apply it. These are all vascular locking clips. For the additional safety, we have applied on the proximal part, and now the artery is being divided. Once it is done, our tunnel was already made, so we divide with the stapler. This is a purple stapler, tri-stapler technology, where there will be a graded size of staple length. It's a very good stapler. So this is being divided. Stapler has made advanced laparoscopic surgery a very good instrument for this. So once the stapler is fired, you can clearly see the portal vein below, both the edges of the pancreas, the cut edges of the pancreas. Now the challenge was how to maneuver the entire cyst, because if I lift it up with the other instrument, there are chances of a spillage. So slowly I just separating the cyst from surrounding structures. Though the planes are very good, the patient hadn't any history of pancreatitis. It was difficult. It was easy for me to dissect because the planes were very preserved. Small tributaries from the portal vein is being dissected off and always being clipped. Always have a good encircle it and just it's clipped and being divided. The difficult part was the portal vein, a splenic vein. which was actually engorged, and it was densely adherent to the cyst wall. But we could be able to dissect it. Make sure before firing you have a very good length, otherwise the clipping will be difficult. So again, 2 clips on the proximal part and 1 clip on the distal specimen side. Once clip is applied, the vein is being divided. Vein is very notorious than the artery. It never forgives. This is what dictum in our surgery. So now after that, the lower part of the cystic lesion is being separated from the retroperitoneum. Then we had a thought of putting a Nathanson detector. This is actually a detector for the liver, but we use it manually and use just to lift the cystic tumor. So we could able to maneuver it very well. Now you can see easily, this is a part of mesocolon. Entire cyst was separated from the surrounding structure. This is another cystic part which was actually attached to main cyst lesion. A gauze piece dissection, and you keep your area clean, it will give you a good plain dissection. Meanwhile, this structure is splenic vein. Just keep on scaring us not to come closer to us. Always open up the area, have a look on the plane, and just divide in a plane. Now the assistant is detecting the pancreatic edge on the lateral side, and then we are dissecting medially and separating from the vascular structures. This was the cut edge of the splenic artery. Slow and gently dissection is very important. There are few tributaries. Sometimes a bipolar dissector is also useful in this type of settings. Once entire cyst was lifted up, these are all adhesions. Now we can able to see a spleen posteriorly. Otherwise it was not visible previously. You can see spleen behind. Now the remaining short gastric vessels which was not visible now is being divided till the end. The lower pole attachment and the lino-renal ligaments and all the ligaments of spleen is being divided after that. These are all avascular ligaments, so it's very easy. Patient was little bit overweight, that's why the omentum was very bulky. You can see a part of tail of the pancreas was visible here. So it was being dissected off. This is the tail of the pancreas. This is the lino-renal ligament. Gently counter traction and traction is very important. This is a splenophrenic ligament. Once everything is divided, our biggest challenge was how to remove the specimen. Kothri goto, kai kothri goto. And suddenly my assistant suggested that there is a large endo bag which comes in a Euro bag. So we thought of that, and now this entire specimen is being bagged. Initially we thought it will definitely take longer period of time for the bagging of specimen, but it hardly took 2 minutes for us, because specimen was like going inside with the gravity. હવે કોથળી આખી ભરાઈ ગઈ. Entire specimen was inside. Now approximately of 3 centimeter incision just above the umbilicus, we have punctured the cyst, and you can see the mucinous structure. The sting sign is still positive. This is suction sting sign. You can see. So entire content was sucked out. Spleen was little bit of, we just removed it with a sponge, and you can see hardly it was a 3 centimeter of incision. There was no blood loss at the end. We have sucked everything. It was absolutely full hemostasis achieved. The total blood loss was around 50 ml. We capped the drain, the splenic fossa. Now the patient is doing good. This is the port site. You can see hardly 3 centimeter incision from where we have removed the entire specimen. Thank you very much. Now another I don't know to show that picture again. Everybody is looking at the screen. So just yes. Do I have a little bit of time? I'll just fast forward it. No problem. No. Okay. Fine. This was the lady. I think this case was, I already discussed with the surgeon, so I think most of the surgeon will be knowing of this case. But for all the new, all other doctors, this is a new case. A 24-year female patient. She's had a history of a bariatric surgery almost 3 months back, and she presented with abdominal pain since 2 days, and she was in sepsis actually, and there was a septic shock. We have resuscitated her. Her BP was initially 124/90. After that, it goes down and went into a septic shock. We resuscitated her, and actually it was a lab banded sleeve gastrectomy. Her BMI was 43, and she had no other comorbidity except PCOD. So we thought of some peritonitis. So this was the CT scan done. So CT scan was showing, I discussed with the radiologist 2 or 3 times. He said the contour of the pancreas is not, the stomach is not good. There is a perforation and there is a leakage of the contrast. Her create was bit high, that's why we have done a plain CT scan. So the intra of finding surprises us. These are CT scan images. We always use a VZ port on this type of patient. Once we have entered inside, there was lots of pus inside. We couldn't see any stomach or liver or anything else. Everything was fully flooded with the pus and pus flakes. Entire liver was covered with the pus flakes. So slowly and gently with the suction, we have just sucked out everything. By the time patient was a bit stable, so I could able to progress with the laparoscopy. Good anesthesia team is always better for this type of surgeries. You can see everything was stuck. Not a single structure is actually identified. Where is the stomach, where is the colon, where is the omentum. So on the right side also there is lots of pus. So gently and slowly all the pus flakes were dissected and sucked out. We'll show you. Klebsiella. So this is the nascent dictator which I showed you in a previous surgery. So now at the end of little bit of sucking and all the dissection, I could able to lift the liver. At the area we can find something here. This is actually a necrotic patch, and now what I am dissecting is the band. Now this is being lifted up and it is divided. Now we can see the area above the band was totally dilated, and once I divided the momentum, the entire posterior wall was sloughed out. Entire posterior wall. It was gangrenous and fully sloughed out. Anteriorly it was a small patch, you can see here, but posteriorly you can see even the food material was there. This is the food material, and you can see the posterior wall is totally sloughed out. Need a good suction for this type of patient. So slowly all the food material, everything was sucked out. Now the challenge was, should I dissect it more or should I convert it to open? But everything was fine. Anesthetist was telling patient is doing good, you go ahead. I simply keep on dissecting. As I approached towards the pylorus region, I could able to see a good and a normal looking antrum and pylorus. So you can see entire posterior wall was totally sloughed out. The posterior part of the band also released, and the stomach is being divided at the level of antrum. Just antrum and the body level. You can see the posterior wall is good. So this is actually a proximal gastrectomy. Again, a purple cartridge was used. One more fire. Now these are all the left gastric vessels. You can see these are all left gastric vessels. So this is also being clipped and divided with a harmonic. As patient was very young and she was holding all the parameters, the contamination was only on the supracolic part. This is the GE junction, this is the stomach, and this is the esophagus. This is the esophagus. Now is fully being divided. Again, specimen was bagged. And removed. Now you can see each and everything is very much clearly visible. We have given almost 8 to 9 liters of saline wash. You can see now esophagus is being, the wall of esophagus is also good. We have just mobilized a lower esophagus bit so that we have a good length for the anastomosis. Once this is done, we have come down for the Roux-en-Y limb. So approximately from the 20 centimeter from the DJ, we have divided with the stapler. We have marked the limb, and approximately 60 to 70 centimeter of Roux limb is created, just to make sure that it should be a tensionless. Then jejunostomy was done, and it is being done with the stapler again. The enterotomy was again closed. Here you can see there is nothing, there is not even a small drop of pus in infracolic compartment. This is a retrocolic anastomosis. We have repressioned the margin of esophagus, and end-to side anastomosis in a single layer by the PDS 20 was done. By the time, at this point of time, you are already exhausted. and suturing almost comes at the end of surgery. So you have to be very careful. I'll just fast forward it. So anterior is also open and the drain was kept. Patient was on ventilator, and after that she recovered well, and we could able to discharge her at the end of 20th day. And this is her recent photo eating pizza, and she lost good weight and she is maintaining as well. And a few months back she replied me, and she won the runner-up contest of Miss Gujarat. એક છેલ્લો છે બતાવવો હોય તો ચાલશે, બાકી ચાલશે. We have one more presentation, so thank you very much for your kind attention, please.
Anyone have a question? Popat sir. Popat sir has a question.
Yes, sir. Thank you, sir.
And you have done with the laparoscopy, distal bacteria and this surgery. This is also very difficult.
Thank you very much, sir. Thank you.
For mucinous cyst adenomas like this, I usually prefer a financial incision, especially the patient is a very obese and all. Most of these are obese patient. The financial is something which is of something, you know, it's a, for us is a most commonly used incision for specimen retrieval. We use it for specimen retrieval. If at all there is a, you know, underlying malignancy in the specimen, probably, and being a mucinous variety of the cystic neoplasm, probably I would say the intact specimen with financial would be a right choice.
Okay, thank you very much.
For felicitation of Amit Bhai, I would like to call Dr. Vimal Hemani sir and Dr. Sunil Lukani sir for felicitation. Please come on the stage. So we are heading towards the end of this CME, but one lecture is pending. Dr. Mohit Bandari, who is supposed to take a next lecture, is due to some unavoidable circumstances, is not with us, but he sent one video for us, and we are going to look at it. Before we play the video, I would like to give a small introduction of Dr. Mohit Bandari. He is a director of Mohawk High-Tech Hospital. He is the most experienced in bariatric surgery in Asia Pacific, who has performed more than 15,000 bariatric surgeries. In 2007 also he introduced endoscopic sleeve gastroplasty, a non-surgical weight loss procedure in India, and he is the first Indian doctor to perform a single anastomosis duodenal ileal switch surgery. So we will play one video which he sent us for us, and then this is our last lecture. So please hold your glucose level.
Good afternoon, everybody. This is Dr. Mohit Bandari from Indore in India. I bring greetings from Indore, from Sri Aurobindo University and Mohawk Bariatric and Robotic Surgery Center. I work with Professor Manuel Galvao, and I'm a consultant to Apollo Endosurgery, Pentex and Olympus. So I leave it to your wisdom to judge my lecture in the light of my disclosures. Manuel Galvao joined Mohawk Bariatric and Robotic Surgery Center around a year back, and he's the director of bariatric services, bariatric endoscopy services here at Mohawk Hospital. So the first 5 years of my international exposure was built in by Professor Phoebe, and we still continue, and Manuel is the next one to expose India and our department to the most international modalities we have, and now this has become a household name. Uh, I've done close to 17,000 bariatric procedures at Indore and around 2,000 procedures outside Indore at different other centers like Mumbai, Hyderabad, and Ahmedabad. But more importantly, we have contributed extensively as far as India and Asia is concerned to the endoscopic procedures in last 4 years. So you can see that we have done couple of swallow balloons, endoscopic sleeves, and several others, and that has made a very interesting and remarkable difference in the kind of case mix we have. So like any other center, we started from sleeve gastrectomy and now our journey with the swallow balloons. But we know that endoscopic treatment or endoscopic bariatric therapies, they play a very important role because everybody cannot undergo bariatric surgery, and at the same time we know that most drugs.
Though we have a time constraint and video is very long, I'm going to play a certain good video of him and an important part of the lectures only.
Drugs which have been approved by US FDA, RYGBs or the sleeve outpatient procedure. Because if you do a full energy source with the pouch tightening and outlet reduction for weight regain. Let's talk about the primary therapy. So first let me discuss about endoscopic sleeve. We are the first one in the country to start this procedure. It's very simple. There's a overstitch device by Apollo which used to suture, and this particular device is a little complicated because if you do a full thickness endoscopic suturing of the stomach starting from the antrum coming up till the fundus of the stomach, and that's the device where Proline 20 suture is being used.
Prepare to load the needle body by closing the needle driver handle.
What we principally do is, take full thickness bites by this particular device and oppose the mucosal surface of the stomach. So healing basically takes place by mucosa and serosa, but it's a full thickness bite. And if we see here, I think most surgeons would know what exactly endoscopic sleeve would mean, but this is the device, and once these sutures are taken, this is a cinch which is used to basically keep the device in place. So this is, very simple procedure of full thickness endoscopic suturing and very popular also. At the same time, we have now the single lumen device. We don't need a double lumen scope to do this particular procedure, and it does exactly the same what the single lumen device does. Basically create a tubular stomach, just like you see in laparoscopic gastric plication. And this can be done by endoscopy. There is no incision on the skin of the abdomen required. And we are just coming close to 1,000 of these procedures, which is the largest volume probably in the Asia Pacific region taken together. Our center with after Manuel joining us. It's a complex procedure definitely, and it involves a lot of instrumentation because India doesn't have a double lumen scope, single lumen scope or device, pardon me. So we are using the double lumen scope still, and we use this Apollo overstitch device, which has there's a needle exchange catheter there. So that's there, the needle exchange catheter. This is the Apollo overstitch device, and you can see the device is mounted on a double lumen scope like that. There are different suture patterns. I'm not going to go into the details of these patterns, but these are the different suture patterns you can use. At the end of the day, the ultimate aim is to reduce the lumen of this particular stomach. And once the lumen is reduced, we get something like a sleeve gastrectomy. Again, you can see this is a helix which is pulling the tissue. We use a full thickness device to take the suture. And once the suture is taken, we can, oppose the two layers of the stomach to create a tube. Something like this, where there is a principle of delayed gastric emptying. You see a very thin tube, just like this. And when we do radionuclide studies, we feel that there's a delayed gastric emptying here. So 240 minutes, the radionuclide does not come into the pylorus. And that principle is exactly opposite to sleeve gastrectomy, where we find that it's very different. In sleeve gastrectomy, you have a GLP-1 secretion. We all know that there's a fast transit time. So this is how it looks from inside. So you can see I have both the endoscopic and gastroscopic view. A nice tube being made, and this is something very interesting. You will not find this video anywhere else, because what you are seeing here is both the things. So you see here, this is the laparoscopic view, and at the same time you see here the endoscopic view. So how it looks in laparoscopy when we do an endoscopic sleeve. Usually we never put a laparoscope, but this was a special case where the patient had very severe non-alcoholic steatohepatitis, and this guy was referred to us by a gastroenterologist. He wanted liver biopsy, so we did a nice laparoscopy. Again, the physiology is of a delayed gastric emptying, you can see here. And if we see the procedure, this is the helix pulling the tissue, and we take full thickness bites. And this is done in a U-shaped pattern. We don't go towards the lesser curvature of the stomach because it obstructs the lumen. And that's how we create a very nice lumen, by taking this full thickness bites. This is our experience at Mohawk Hospital. We have done cases where we had a very good weight loss of 20% at 12 months, almost fantastic resolution of comorbidities, and we published this as a standard procedure. Along with us, Barham, Abu Dhabi, and several others across the world are required to establish some sort of competence in endoscopic sleeve. And the same principle of gastric apposition, but the device is loaded through a different scope. It's a pediatric scope. This is the same like endoscopic sleeve, but here they say that this is more durable. We are starting with the post-2 program at our center very soon, so we will come up with our own data comparing endoscopic sleeves with the post-2. So I'm not going to go into a lot of these, but I will talk something about the swallow balloon. So this is the new program we started at Mohawk Hospital. It's no surgery, no endoscopy, no anesthesia balloon. Patient will use to swallow this balloon, then it is filled at the same time. It's a 5-minute outpatient procedure, and patient can go home. The balloon passes in motion after 6 months. So we have done 110 cases till now. Fantastic weight loss at second month of around 7.80%. This is our video, so you can see that this is being done inside the hospital. You give the capsule to the patient swallows it with water very easily. You take an X-ray and confirm that the pill is inside the stomach. So the patient takes an X-ray, and once the X-ray is confirmed, you do the filling of the tube. And once the filling is done, as it's seen here, another X-ray is taken to confirm that the tube is particularly filled. And then, after the second X-ray which is being done, and you see that the balloon is in place, the tube is being removed, and the patient is discharged. This entire process takes 5 minutes to 7 minutes. And I think all these balloons, Orbera, Reshape, Spats, Ellipse, the Ellipse one is a 550 ml balloon, which I think by Allurion technology is going to survive the test of time. Rest all balloons, when you talk about, either they have very poor tolerability, or the weight loss is not sufficient and bad GQLI score, and giving anesthesia for 2 times to put in the balloon and to remove it will not, make them very popular in times to come. Endobarrier sleeve is another procedure which is based on the foregut hypothesis. We put a silicone polyethanol tube called as endobarrier, and we all know the mechanism that as the food will pass, bypass the first and the second part of the intestine, the foregut comes into play, and that's the area where the benefit of type 2 diabetes is being taken, as we all of us know. So this is just to mention here, this still being done at different, in different locations, just as a part of a study. The first device went out because of a lot of liver abscess, DO perforations, but the second device again is being tested now. It's still not approved for the clinical use. Let's talk about the magnetic anastomosis. Again, this is something which is still not approved for the clinical use, but it's very interesting. It might, in 2 or 3 years to come, might become a standard of care. So endoscopic sleeve in combination with magnetic anastomosis can become the standard of care, just like a gastric bypass. You can see this kind of procedure coming up in future, and the studies are going on. Manuel is working on it, and hopefully we'll be able to do first of its kind in India. So you see on laparoscopic evaluation, it looks so beautiful. This is the anastomosis here, and that's the kind of thing which we expect. And I think that's going to be the future of laparoscopy, the endoscopic procedure. Mucosal resurfacing, this is something which I'm getting involved with. The DMR project, it involves circumferential hypothermal ablation of the duodenal mucosa. The mucosa is lifted with the saline to protect the outer layers of the duodenum, and then the mucosal resurfacing is done. A very interesting procedure, and now what they're doing is that with this catheter they burn the mucosa, and once the burning is being done, the ablation being done, this takes care of the type 2 diabetes. So you basically first lift the duodenal mucosa, and once the duodenal mucosa is being lifted, you give circumferential burns to it, and once the circumferential burns are given, you have a mucosa which is completely ablated, and that particular mucosa will not do absorption, and then that takes care of the diabetes. So this is, a lot of studies are being published again here also, but it's still, it will come to India very soon, where me and Manuel are going to bring the first DMR program, but we'll put our data forward. I'll not talk much about it now. The secondary therapies, as you know, for weight regains, revision surgeries, obviously you give an argon energy source where 65 to 75 watts at 2 to 3 liters of flow burns on mucosa, and what we see is this. So this is being done at our center very regularly. You see, this is a revision case for endoscopic sleeve, where you can again do an endoscopic sleeve and take care of the stomach which has failed. So this is the beauty. Endoscopic procedures can be repeated. At the same time, you have the procedures where you can repeat them for n number of times, as much as you want. Same time, as I talk about the argon energy source, you can give the circumferential burns as shown here. These burns are given to create fibrosis and to create good base for the endoscopic sutures to be taken and to reduce the outlet. And then a full thickness suturing is done to reduce the outlet and also to reduce the size of the pouch. So again, this is being done regularly at our center. We do revision courses for bariatric surgeons who want to learn these techniques quite frequently, and me and Manuel would be glad enough to train all of you to do all these procedures. The same can be done for Roux-en-Y, and the same, as I said, give circumferential burns to the outlet. You can see here. And then obviously use a full thickness suturing device to reduce the outlet and the pouch both. We do regular courses on revisions on endoscopic sleeves for weight regain after sleeve gastrectomies, gastric bypass, and mini gastric bypasses, and we club them alongside the surgical revisions. And all of you are welcome to attend our courses. We'll announce the courses for this year, and you can register for these courses. So what I would say that the overall treatment for obesity requires a multidisciplinary approach. You need to have endoscopic technique in your armamentarium to treat certain number of patients who do not deserve a bariatric surgery, who do not want a bariatric surgery, or who are very high risk for bariatric surgery, and that would, believe me, 90% of your practice. So if you do not have endoscopic procedures in your armamentarium, you are not a complete bariatric surgeon. At the same time, the other spectrum, the complications, leaks, bleeds, strictures, stenosis, and obviously weight regain requires endoscopy. So here is for you. You have to learn endoscopy. You cannot escape away from it. Dr. Phoebe taught me that whatever we do as an innovative approach, we should always maintain our database, put our data in a prospectively maintained audited database, and then assess where are we going. If we have negative results, we should report them. So a negative result is not a loss of face. It's just a reflection of your wisdom. Thank you very much, everybody.
Thank you, Amit Bhai. Thank you for conducting and playing this video. So we are come to an end to this CME. It was really wonderful and informative CME today. Before giving word of thanks, I would like to give information about our two upcoming events for IMA. One is next Saturday and Sunday, 12th and 13th of March. we are having a IMA Olympics. All the sports activities like swimming and volleyball is on 12th Saturday at Doctor Clubs. And on 13 we have all the indoor games, badminton, table tennis, chess, carom, and athletics like running. So be present on that event. We have more than 600 entries from our IMA members and family members. So please come to visit and watch the entire sport event. We are conducting this event in a first time in IMA. Every year we are conducting a cricket activity, but from this time we are conducting and including this all the Olympic and all the indoor games, athletic games, swimming and all that. So can our IMA family members can also participate in this. So please visit on both days we have activities, please visit that. Then we have on 18th March, Friday, we have our Duleti program, Rang Barse, from 9 a.m. to 1 a.m. at Angan Party Plot. Please come there. We have a dance, DJ, rain dance, and all the Duleti stuffs and Pagalpan. Please visit that and please do registration for that. We have a one Google form which we have broadcast through IMA number. Please register that. It's a complimentary but register so that we can have a better management for that. And then 3rd April we have a final installation ceremony for the next IMA committee. For today's event I want to thank all the Prime team. It was such a wonderful CME and we hope we would have one CME every year from Prime team, hopefully. And they are coming with the different topics. And because this is our Rajkot's hospital and this is our IMA. So if we get a CME from our local Rajkot team, we are also very much happy because from Ahmedabad, Mumbai, all the teams are coming. But we like that our Rajkot hospitals encourage our IMA and conduct this CME. So I want to thank Dr. Rawal sir and all the team for such a wonderful CME. And I would like to thank all the IMA members who have attended today this CME, committee members, organizing committee members, and our ground staff, Sandeep, Dharmesh, and Nilesh Bhai. Thank you all. So we can now proceed for lunch. Thank you.